to annual Dr. Joseph St. Elmo Hall Memorial Lecture on cervical cancer. Dr. Joseph Elmo Hall joined the Jamaica Cancer Society in 1968, and on his appointment as a lecturer of obstetrics and gynecology at the University of the West Indies, he started seeing patients with abnormal cytology reports in society's clinics in 1972 and became the official, I would say, gynecologist to the Jamaica Cancer Society. Now, Dr. Hall introduced the first USA-trained cytotechnician into the pap smear program, and he undertook a national 2-year pap smear program, opening access at public health clinics. Fast forward, this was highly successful, and he's a member of the board of the directors of many years. Dr. Hall unfortunately passed October the 14th, 2016. Now, since then, we've been having annual conferences in honor of him and the reduction of the incidence of cervical cancer in Jamaica. So I'm proud to say this morning, welcome everyone to this lecture. At first, we will promptly start in our program. The program as scheduled is Miss Charmaine Robertson, the Director of Health Promotion of Public Relations and Customer Care for the National Health Fund.
Morning, Dr. Christopher Daly, and of course to the members of the Jamaica Cancer Society who are on. Also want to recognize the speakers and conference participants. You know, NHF recognizes the valuable role the Jamaica Cancer Society plays in cancer awareness and education. And we want to praise the work of this NGO. NHF has partnered with the Jamaica Cancer Society over the years, and we will continue to support its activities. The impact of cancer on one's life is very significant, and NHF has provided financial relief with subsidies for pharmaceutical drugs for the treatment of cancer. So in addition to breast and prostate cancers, since 2023, the NHF now covers subsidies for medication for colorectal cancer, lung cancer, and multiple myeloma. Last year also, NHF has strengthened its support for disease prevention when screening for prostate cancer was added to the list of diagnostic tests that we cover. Other tests for which subsidies are provided are the HbA1c test and the breast cancer receptor studies test. A subsidy of $1,600 is now provided each year towards the cost of a PSA test. We went on a drive to sign contracts with medical laboratories to accept the NHF card so that they can offer the PSA test. And we now have over 25 laboratories across the island that accept the NHF card for the PSA test. I know you must be asking, given that this conference is about cervical cancer, what about the pap smear? I want to assure you that the NHF has this under serious consideration. Of course, what this will mean if it is introduced is that we will then need to sign contracts with doctors to accept the NHF card for the pap smear, so they can offer this service for the pap smear. Now, the NHF card cannot operate without doctors because under the Medical Act, the registration of NHF card beneficiaries cannot be executed without the medical practitioner's signature certifying patients' conditions. There are nearly 3,500 doctors on the NHF database who have certified patients' conditions since the NHF started in 2023. There are doctors who are very active since the inception of the program. We have seen doctors who have signed up one patient, and we have seen doctors who have signed up more than 600 patients. We have gone a step further to make it easier for doctors to sign up their patients with the introduction of the online registration by doctors. And I want to use the rest of my presentation time to bring this service to your attention. So I'm now going to begin sharing of slide presentation. As I was saying, the online registration for doctors was set up so that it would be easier for doctors to sign up their patients. The Electronic Transaction Act, this provides for electronic signatures to certify information given electronically. So where a signature is required by law, as with medical practitioners, the signature must be encrypted, and encrypted signatures must have certain criteria. They must be uniquely linked to the person whose signature is required, I guess in the same way that your MCJ number is linked to you. It should be capable of identifying that person, and it is created by using means such that person can maintain under his or her sole control, in the same way that you have maybe your stamp under your sole control, and linked to the information to which it relates in such a manner that any subsequent alteration of the information is revealed. Now, the online registration by doctors allow doctors to directly register their patients for the NHF card. And this can be accessed either via your desktop, your laptop, or your tablet. So in fact, there is no need to have forms in your office. And if you run out, it is not a problem. One of the issues that I know patients have is that the card will be signed up by the doctor and they have it sitting down at home. So this allows the doctor to sign up the patient directly. So how do doctors get on board? As I know many of you who are not yet on board would like to offer this service to your patients. You'd have to complete the physician commitment form for the NHF card online registration, in which we're asking you, for some information. The expiration, when your MCJ certificate expires, your professional registration, your contact details, and in expressing your interest, you acknowledge your professional duty to validate and certify patients' medical information, that you will keep and secure your credentials, and that the information contained in this form is true, and then you'll sign that form and submit it to us. So you can send this form to the provider relations team, and they will activate your credentials and bring you on board for this program. And an email with instructions for access and upload of the electronic signature will be sent to the doctor. And there are three credentials that you'll need: your username, your email address, your password, and of course, your electronic signature. And this signature will be generated and provided to you by the NHF, which was your unique signature. So when you go online to sign up your patients, of course, you will see this login in which you'll need to provide your email and your password. And then on the platform, you will need to put in the patient's name and their TRN number and their telephone number. And then you will, as usual, you'll certify the following conditions. You'll put in the usual information, include the signature, add this signature file that was provided to you, and submit that application. Now, what happens when you submit this application? It will be seen by the customer service team. They will make contact with the patient, and they will complete the other aspects of the form, and they will print the card on arrival of the patient of the NHF card center. We have 21 centers across the island. So, when they call us, they can pick it up in Montego Bay, Morant Bay, any of our 21 locations across the island. Now, if you're interested, there are a number of ways to contact us: on web chat, by email. You can also visit our office if you're passing by and have the time, and visit our social media pages. So thank you very much for listening. And let me just say that I look forward to a wonderful conference as we all work together to improve healthcare in Jamaica. Thanks, and back to you, Dr. Daly.
All right, thank you very much. Just reiterating that NHF is a proud sponsor of our program today. My name is Dr. Christopher Daly, obstetrician and fellow obstetrician and gynae oncologist as well, who will act as your moderator for today. Miss Shillian Brown will bring forth the greetings on behalf of our chairman, and she's the public relations officer of the Jamaica Cancer Society. Miss Brown, are you on?
Yes, I am, Dr. Daly, and good morning to all, and good morning to our representatives of the Ministry of Health and Wellness, representatives of the Jamaica Medical Association, Jamaica Cancer Society team or ICT team, or presenters, and other members of the medical fraternity, ladies and gentlemen. I extend a warm welcome to everyone to this annual Dr. Joseph St. Elmo Hall Memorial Lecture on behalf of our chairman, Mr. Earl Jarrett. So the lecture is the final activity as we bring the curtains down on our activities to commemorate Cancer Month, April 2024. During Cancer Awareness Month, we, the Jamaican Cancer Society, use the opportunity to further heighten awareness about our work and reinforce the message that cancer is not a death sentence. Our organization is dedicated to reducing the burden of cancer. As we have done in the past years and we continue to do today, we are focusing our efforts on sharing that through screening and continuous learning, persons can prevent or arrest these diseases. By doing simple examinations, women can defeat cancer and also achieve a healthy, productive life. For this year's lecture series, our focus is on two of the most prevalent cancers among our women: cervical and ovarian cancers. These areas for discussions include cervical cancer landscape in Jamaica and the Caribbean region, screening, diagnosis, and types of treatment for the disease, how it presents itself in young people, and how, as a nation, we are responding to internationally established goals in regard to treating with this disease. We will also have a robust discussion on the silent killer, ovarian cancer, and look at the impact of these diseases on our mental health. Today's session promises to be rich as we explore these areas and delve into new approaches to manage and effectively treat these diseases. The Jamaica Cancer Society is always open to engaging discussions as we seek to find practical solutions to preventing these diseases and, where necessary, managing them so as to improve the quality of lives of Jamaicans and our fellow citizens of the Caribbean. Nobel laureate Amrita Sen described health as one of the most important conditions of human life and a critically significant constituent of human capabilities, which we have reason to value. I anticipate that following on today's session, we will reaffirm the value of the quality of life that is available to persons who may be diagnosed with these diseases as we refine current remedies and develop new workable solutions to move Jamaica and the region farther along the path of cancer prevention and treatment. Once again, I welcome you to this seminar and wish for you a very productive day. Thank you.
All right, thank you very much for such a warm welcome and introduction. So you'll notice on our program, we have Dr. Paul Mitchell. He is a consultant, obstetrician and gynecologist. He works at the Victoria Jubilee Hospital, and he is a graduate, both undergrad and postgrad degrees from the University of the West Indies. Interesting fact that his special interest is in athletics. Not sure if that's running himself or watching, but he's married and faith-based person, I promised. So he's here today with the privilege of presenting to us information relating to the screening, the diagnosis, and the treatment of cervical cancer. What is new? What is the updated information we can expect from Dr. Mitchell? Mitchell?
Good morning. Thank you for having me. Screening, diagnosis, and treatment, what's new? So every 2 minutes, a woman dies from cervical cancer. It's the most common gynecological cancer worldwide, and the second most common malignancy affecting women secondary to breast. And it's the second most common cancer in women between the ages of 15 to 44 years. According to Iraq, in 2020, it is estimated that over 600,000 women were diagnosed with cervical cancer, with almost 350,000 deaths each year. In Jamaica, approximately 200 women die of cervical cancer annually, and our age standardized rate for cervical cancer in the KSA registry was 15.7 per 100,000 in 2008 to 2011. Our mortality rate is about 11 per 100,000. The burden of the disease is associated with multiparous women who are the matriarch of our Caribbean society, developing countries, and underdeveloped screening programs. With proper screening programs, there has been seen a decline in the disease in some developing countries. This is as a result of the Human Development Index. The Human Development Index is a measure of education, life expectancy, and gross domestic product. As the Human Development Index increases, the cervical cancer rates decreases. Risk factor for cervical cancer: early onset coitarchy, promiscuity, exposure to HPV virus, history of sexually transmitted infection, high parity, immunosuppression, low socioeconomic status, and previous squamous dysplasia of the vulva and vagina. How do we prevent cervical cancer? There's a three-pronged method of preventing cervical cancer. One, by HPV vaccination, which usually starts at age 9 to 26 years, and you can give up to age 45. Secondary prevention, where we talk about giving our pap smear or HPV testing or both. Or tertiary prevention, where we do colposcopy, loop excisional cone biopsy, and ablation. There's over 40 different types of HPV, of which 15 is considered oncogenic or high risk. The high risk type, the most common, 16 and 18 and 45, followed by 31, 33, 52, 58, 59, 35, and 56, and so on. It is the most common, HPV infection is the most common genital sexually transmitted infection worldwide. And some women remain persistently carriers of this virus and become high-risk progression to precancerous lesion and lead to cancer of the cervix, vulva, vagina, and anal canal. In male, it can affect both penile as well as anal. In younger women, HPV 16 and 18 tend to be more persistent. For 15 to 25 years age group, the disease is 80% usually transitory. That is, it will come and go or wax and wane. In the older women, it tends to be persistent. Pap smear was first introduced by Pap Nicola in 1941, and since then, it's been a screening tool worldwide. There are two main different types of cervical cancer. One with the ectocervix, the squamous cell from the squamous epithelial on the transformation zone, and one in the endocervical canal, which is the adenocarcinoma. This is a picture of what a cervical cancer looks like. As I said before, HPV 16, 18, and 45 cause 90% of adenocarcinoma. That's a non-squamous cancer type. Squamous cancer, even though the most common, at 70%, there's adenocarcinoma 25% and adenosquamous 3 to 5%. Adenocarcinoma is more aggressive, has a poorer prognosis. It tends to metastasize early, and it's usually associated with a negative cervical cytology or pap smear. Multiple studies have found that screening reduces the risk of cervical cancer, but much more so for squamous cell carcinoma. Fletcher et al. Found that 90% of women who died from cervical cancer have never actually been screened. What's the significance of screen? basically prevent cancer. HPV is responsible for 90% of cervical cancer. 70% of abnormal paps are seen in the United States versus around 8.4% in Jamaica. CIN3 has a 30% risk of progressing to invasive cancer in 30 years, and treated CIN3 will progress in 1% of cases. In our national screening program, we were trying to achieve 60% reduction in the cervical cancer mortality rate. We have a lot of work to do. 80% of screening occur between the ages of 21 to 44 years, and this should be done at least every 2 years. Screening should be initiated within the first 2 years of coitus in immunocompromised women and at 21 for the others. Screening in Jamaica, again, has its challenges. 1, the attitude towards screening. 2, delayed reporting. 3, poorly staffed laboratory. 3, poorly equipped laboratories and inadequate recall. The United States Task Force of Preventative and Screening Task Force found that you do not necessarily have to screen below the age of 21 years, because you would have to screen far too much individual to pick up any disease. So the screening guidelines suggest that you start at 21, and it's reasonable to do cervical cytology every year. Why not HPV testing? Yes, you can do HPV testing, but as said before, HPV testing in these individuals tend to be sometimes transitory. That is, it comes and goes. The body will replenish itself. However, after the age of 30, this is no longer transitory, but rather persistent. And so you can either continue with your cervical cytology, or you use high-risk HPV testing every year, or you can use a combination of both, which is HPV testing. Over 65 years, if you have never had an abnormal pap, then no screening is acceptable. However, if you have abnormal pap, screening should be continued for the next 20 years. Cervical cytology screening techniques. There are 2 main screening techniques. They use the conventional cytology, where exfoliated cells from the transformation zone are put on the slide and fixed with 95% alcohol, or you can use a liquid-based method. Exfoliated cells are then collected from the transformation zone and transferred to a liquid preservative and taken to the lab. Another method is that you can use visual inspection with acetic acid, and lesion is usually identified at inspection. The good thing about visual inspection with acetic acid, if you put the acetic acid on the cervix immediately and you see aceto white instantly, then you know it's high grade. If it takes a while, like a minute before it changes, then you know it's low grade. Advantages for liquid-based cytology is that you can do HPV testing with a sample, as well as you can evaluate for abnormal cell cytology, as well as you can test for sexually transmitted infection. In a meta-analysis, they show that there was no significant difference between the liquid-based cytology and conventional cytology. The Bethesda classification came about in 2001. Bethesda classification was at a convention in Bethesda, Maryland, where they came about with a convention for both liquid-based and conventional cytology. The adequacy has to be that they have the presence of endocervical components. General categorization means that there's negative, if it is negative for intraepithelial cells, or if there's any organism or non-neoplastic findings. The report would suggest if it is atypical cells with high grade, low grade, high grade, squamous carcinoma, atypical cells with glandular cells of undetermined significance, atypical cells which high grade cannot be ruled out, adenocarcinoma in situ or adenocarcinoma. What's new about testing? Is the high-risk HPV testing the end of cervical cytology or pap smear? In the past 10 years, they're contending views for females over 30 years. Now it's broadly accepted in developed countries that if somebody is HPV negative, this can be done alone as a standardized test. And this is done, if it's negative, then a patient can not undergo screening for the next 5 to 10 years. However, if the person is immunocompromised and the test is negative, then the patient should be screened every 3 to 5 years. If it is positive, then the patient may be referred for colposcopy. High-risk HPV testing is another screening tool which can be used in low-resource setting, as seen in a study out of Cameroon, where they had persons self-testing as well as physician-guided testing. Women between the age of 30 to 49 years were recruited for this screening campaign, and HPV-positive women, 3/4 of who were treated with thermal ablation because of abnormal pap smears, were invited to participate in the study. 188 women were invited and attend the follow-up. And what it found is that while the overall performance of doctors directed HPV testing at 6 months was slightly superior, the self-HPV tested showed an improvement in the sensitivity for high-grade HPV at 12 months. In conclusion, because the significance, the difference between self-testing and physician-guided testing between 6 and 12 months corresponded to a K-value of 0.62 and 0.52 respectively among women who were treated with thermal ablation. The self-testing was as sensitive as the doctor directed. And so it is now considered a reasonable tool. And in some countries, they're doing self-HPV testing at home and then they mail it to their physician. Cervical cancer, people who present with it may be asymptomatic. Some will present with abnormal vaginal bleeding. And this is a problem in our context because we use a lot of Depo-Provera injection. So a lot of patients may misguide what is happening to them. Because they are on the Depo-Provera and have the intermenstrual bleeding, they may think it's because of the injection and not thinking it's cervical malignancy. You may have postcoital bleed and a malodorous, watery, mucoid purulent discharge. Colposcopy. So a biopsy is the only way you can confirm cervical cancer. So a pap smear will not confirm cervical cancer. HPV will not confirm cervical cancer. What confirms cervical cancer is a biopsy, and the biopsy must be large enough to demonstrate invasion. You may do a small large loop excision transformation zone, and from time to time there are some optimal biopsy which are taken from the transition from invasive to non-invasive. So a patient may have invasive lesion, but because of where it is biopsied, it can come back as a CIN 1, 2, or 3 because it's transitioning from non-invasive to invasive. And so this may be a problem, especially in the center of the tissue where you may have some tissue necrosis. Tumor may bleed heavily and may have to be packed after biopsy. In a pregnant patient, you may have to weigh the pros and the cons. However, if you see a obvious lesion, the patient must be biopsied. A pap smear have no use for somebody with a active lesion. Staging of cervical cancer. Staging is usually clinical. Usually in the early days, they use X-ray, cystoscopy, and colonoscopy. But now, with the advent of MRI tend to accurately determine the extent of the disease because of soft tissue. CT PET and CT CAP assessed in a lymph node assessment as well as the presence of distant spread. Selection of women in whom surgery is likely curative will also be determined by these investigations. Based on the 2018 criteria, cervical cancer is broken up into 4 stages. Stage 1, limited to the cervix. Stage 2, invades the cervix up to the upper 2/3 of the vagina. Stage 3, in the lower 1/3 of the vagina, extend to the pelvic side wall. Stage 4, bladder and rectal mucosa, and 4B, distant spread. Stage 1A is usually microscopic, less than 3 millimeters in depth to less than 4 millimeters in width is stage 1A. Less than between 3 and 5 and less than 7 millimeters in depth is 2A. It may seem very small, but there's a significance to this, and I'll point it out a little earlier. Stage 1B, less than 2 centimeters. 1B2, less than between 2 and 4, and 1B3 greater than 4, and so on and so forth, as you see on the screen. The importance of what I want to allude to you is that patients with 1A2 tend to have up to almost a 5% chance of nodal spread, which is very important to note. And hence, those patients tend to have to be treated more aggressively than a patient with stage 1A. So some of the prognostic factors is that there's increased risk of recurrent following surgery for early stage disease when the tumor size is greater than 4 centimeters, when the depth of invasion, then there's increased depth of invasion, when there's positive margins, as well as there is a pelvic lymph node involvement and lymphovascular space invasion. For somebody with stage 1A disease, it can be treated with hysterectomy or cone knife cone. In a study of over 1,400 women less than 40 years old with stage 1A, there was no significant difference in the 5-year survival rate between somebody who had conization and hysterectomy, with 98% versus 99% respectively. One should know that 1A2 had almost a 5% chance of lymph node involvement. 1A2 management of the stage is more controversial because the lymph node must be assessed because of what we aforementioned. In patient who has fertility desires, a trachelectomy and lymph node dissection may be considered. If not, you can do a radical hysterectomy or possible hysterectomy and lymph node dissection may be recommended. For stage 2B, stage 1B, if the patient is fit, a radical hysterectomy is the preferred treatment of choice. In the past, minimal invasive procedure was a thing for cervical cancer. It wasn't until 2018 when Pedro Ramirez et al. Did a multiple randomized trial comparing laparoscopic radical hysterectomy to open procedures in which they used women with stages of 1B, 2, and below with histological type of squamous cell adenocarcinoma and adenosquamous carcinomas were randomized with 319 in the laparoscopic group and 312 in the open laparotomy group. What they found was astounding after they followed up in 4.5 years. What they found that the disease-free survival rate was 86% for the laparoscopic group and 96.5% for the open group. Minimal invasive surgery was associated with a lower rate of disease-free survival than open, and the odds ratio of the disease of recurrence or death from cervical cancer was significantly more. So the 3-year survival was 91.2% versus 97.1%, and the confidence interval was between 1.3, the 95% interval was between 1.63 to 8.58%. So difference that remained after adjustment for age, body mass index, stage of disease, lymphovascular space involvement, and lymph node involvement, it found that the overall picture is that the survival for after 3 years for laparoscopic versus open was 93.8% to 99%. So the conclusion was that minimal invasive or laparoscopic radical hysterectomy was associated with a lower rate of disease survival and an overall and a lower rate of disease-free survival and overall survival versus radical hysterectomy among patients who have early stage cervical cancer. When radical hysterectomy is performed, patients who have intermediate risk, that is, patients who have a combination of final pathology risk factors such as tumor size, lymphovascular stage invasion, or depth of stromal invasion, may, based on the GOG score, undergo adjuvant radiotherapy. Now, an article which was presented in the New England Medical Journal in February of this year, which was conducted by Marie Plante out of Canada, showed that there was non-inferiority between radical hysterectomy and simple hysterectomy with lymph node assessment for low-risk cervical cancer with lesion less than 2 centimeters. Of course, it was a multi-center randomized trial in which 700 women were randomized, 350 in each group. And what she found is that these are follow-up for 4.5 years, and the incidence of pelvic recurrence after 3 years was 2.17 in the radical hysterectomy group versus 2.52 in the simple hysterectomy group. Urinary incontinence was significant in the radical hysterectomy group versus the simple hysterectomy group, as well as urinary retention. And in her conclusion of the study, she noted that patients with low-risk cervical cancer, that simple hysterectomy with lymph node dissection was not inferior to radical hysterectomy in respect of 3-year incidence in recurrence, pelvic recurrence, and associated urinary tract, urinary incontinence, and retention. For people who have future fertility desires, a radical hysterectomy may be performed. This was presented first by Daniel Darjon. Daniel Darjon, over the years, presented this paper in the 1980s. And what it has found is that patients who have small lesion, less than 2 centimeters with no lymph node involvement, they could undergo a trachelectomy. And in a study reviewing over 500 patients, they found that the recurrence rate was around 5%, and the death from the mortality rate was around 2%, which was quite significant. Now, for patients who are unfit for surgery, you want to try something else. The other option of choice is radical chemoradiotherapy. And these are for people with bulky lesion in excess of 1B3, more advanced disease, and the dose is usually delivered by external beam or brachytherapy, as well as chemotherapy. The overall survival advantage using cisplatin chemotherapy given with concomitant radiotherapy, the risk of death from the disease tends to decrease by 30 to 50% with use of concurrent chemotherapy. With the external beam radiotherapy, there is given 1.8 graves given over 25 cycles of treatment. And this technique would call cancercidal effect, giving the normal tissue time to recover between fractions. However, there are some complications include vaginal stenosis, cystitis, proctitis, vesicovaginal fistula, and rectovaginal fistula. What's new on radiotherapy? In the past, at KPH, we usually use a cobalt machine. This machine will spread radiation all over the patient, and the patient will get some nasty side effects, including thermal burns. But now we have linear accelerator using conventional techniques such as intensity modulated radiation therapy, or IMRT. And this tend to target the radiation to the specific area with CT guided, so that only the area which is needed to be irradiated gets irradiated and nowhere else. In the past, we usually use, for shortwave or brachytherapy, we usually use cesium. With the cesium placement, patient need to be under general anesthesia for it to be placed in place, and then the patient is put on their backs for around 48 hours. The client is restricted, and it's not very good for bulky tumors. So this is how it is. It is placed in the fornix, and the tandem is put in the endocervical canal. Now we have interstitial brachytherapy. That's new. Using this applicator, it's close to the tumor, and it's placed through the cervix or perineum. And this applies 20 minutes per day for 4 to 5 days. It's placed directly into the tumor, and this results in you having less side effect, and it's aggressive in treating the tumor. And this is the comparison between the conventional method over here and the interstitial brachytherapy here. And if you notice, it covers a wider area. So the bulky tumor, which is close to the tandem and the conventional method will get treated, while the ones outside won't get as much treated. With the interstitial treatment, then the ones which are closest to the rods get treatment. Now we talk about neoadjuvant chemotherapy. Neoadjuvant chemotherapy, that's giving chemotherapy before surgery or radiotherapy. It may be beneficial for radiotherapy, but it's not the standard of care before surgery due to the duration of treatment and the phenomenon of accelerated repopulation. Management of recurrence. If somebody had previously had surgery, then the follow-up management is usually chemoradiotherapy. And if somebody had chemoradiotherapy, the follow-up management is surgery. Chemotherapy is usually with carboplatin and paclitaxel, and which can be added with angiogenesis inhibitors such as bevacizumab, and these tend to improve the survival rate by 3.7 months. We can also use immunotherapy using pembrolizumab, and this has a better increased survival rate, and its overall survival rate may be as much as 2.4 months. In conclusion, cervical cancer is a public health crisis. Primary prevention with HPV vaccination pap smear and HPV testing will help eliminate pre-malignant lesions and progression to cervical cancer. Advances in surgery will reduce the morbidity associated with low-grade early-stage tumor. An improvement in radiation delivery will reduce the side effects in women and improve their quality of life. Thank you.
All right, thank you very much, Dr. Mitchell. Our next presenter, who is Dr. Natalie Medley. She is from the University of the West Indies. She's a lecturer there. She's a consultant obstetrician and gynecologist with subspecialty training in gynecologic oncology. Today, she'll be presenting on the next topic relating to cervical cancer in a subgroup of patients in the young patient, and the impact of HPV objectives. Dr. Medley.
Okay, hello everyone. I'd first like to thank the organizers for inviting me to share with you today. I am always excited to speak about cervical cancer and the human papillomavirus, or HPV. My talk today is on cervical cancer in the young patient, the impact of HPV. So as we heard before, cervical cancer is the fourth most common cancer after breast, colorectal, and lung cancer. And in 2020, we had about 600,000 new cases and half the number of deaths. Most cases of cervical cancer occur in countries like Jamaica, so developing countries. So we have found that 85% of new cases and 95% of deaths actually occur in low and middle income countries. When we look at the chart here, we can see the world average of about 13.3 per 100,000, and in the Caribbean, we are at about 13.7 per 100,000. Most cases of cervical cancer are squamous cell, and about 10 to 15% are adenocarcinomas and other types. For us here in Jamaica, we're currently at about 15.7 per 100,000. And we have been making remarkable strides with a reduction in our incidence rates. From this review, 1993 to 97, we were at about 25.2, and we can see a steady decline. So that's excellent. We've been doing good work with our cervical cancer. So cervical cancer is most frequently diagnosed in women between the ages of 35 and 44, with the average age being 50. So in doing some further, doing a closer look at our data here, looking at cervical cancer by age group from that review in 2008 to 2011, we saw that there were no cases under age 20 years. We had a bimodal peak, however, where we have one peak here seen at age 50 to 44 of about 48.2 per 100,000. But interestingly, another peak at 60.4 at age between ages 80 to 84. So I found this to be very interesting, and I took a look at the previous review period of 2003 to 2007 and found a similar finding, where we have a peak at about age 50 in keeping with the established literature, but then again at about age 80 we seem to have another peak there in our older women. So cervical cancer is a long-term outcome of persistent and transforming HPV infection, and as mentioned, we know most cases, 99.7% of cervical cancer, both squamous and adenocarcinomas, have HPV DNA detected in them. We have been doing more work recently now, though, looking at cases of HPV-independent cervical cancer, and some reviews actually showed about 10% rate of HPV-independent cervical cancer. Most cervical cancers are caused by HPV type 16 and 18, about 70%. Of this, about 50% of them are caused by type 16 alone. And it's the norm for HPV infections to be cleared. So about 90% of infections are cleared within 2 years, and about 10% or less of women go on to have transforming infections and may develop cancer. So this is just reminding you of the HPV subtypes. There are about 200 subtypes divided into genera and species based on similarities in the L1 protein, the gene sequences in the L1 protein of the virus. And within the alpha genre, where we find all the oncogenic or cancer-causing types, we can see similarities between certain types. So for example, type 18 and 45 are very closely related. So of the over 200 subtypes, about 60 types affect the anogenital mucosa. This slide here is to remind us of the cancer-causing or oncogenic proteins E6 and E7. We know that HPV infection decreases with age generally. So we have a peak of at about ages 20 to 30, and then it declined subsequently. And this is data from 10 European countries. When we look at data from the US, we found that the prevalence is highest in women ages 20 to 40, of about 44.8%. And then we look at increasing age groups, we see a steady decline in the HPV prevalence. Our local data here wasn't able to find data based on age group categories, but overall in this study by Lewis Bell et al. In women 16 to 49 years, we found that the overall prevalence of any HPV infection was 54%, but oncogenic or cancer-causing HPV was detected in 34.9%. HPV 16 was the most common type identified in keeping with established literature. But interestingly, from this paper, they stated that no relationship was found between lower income, lower education, increased number of sexual partners, parity, and so on for high-risk HPV infection. So it's important to tell or let our patients know that, or all of us know these risk factors, but at the end of the day, all women need to be screened regardless of their high or low risk practices. And another study looking at women who were referred to colposcopy clinics. So these are women who had abnormal pap smears now, unlike the previous study. So in this study, HPV 16 was again the most common type detected, and they found interestingly that HPV type 45, which is typically rare, was seen in about 12% of these women, and this was by Dr. Rattray et al. So at what age do women acquire these HPV infections that then go on to become cancer? So we know that the risk of acquiring HPV infections peaks shortly after the sexual debut and then declines with age. The peak incidence of cervical cancer occurs about 20 to 30 years after the population median age of sexual debut. But the age at which women acquire this causal infection that ultimately progresses to cancer is uncertain. What we do know is that HPV vaccination is most effective in HPV naive patients or persons. When we look at the vaccine trials, when we look at women who are HPV naive, so have never been exposed to HPV, are tested negative for HPV at enrollment, versus those who are positive for HPV, we actually see higher efficacies of 98%, 100% in the HPV naive patients versus the HPV exposed. Hence the push for vaccination at an earlier age. So we know that vaccination efficacy is dependent on the proportion of causal infections which have already occurred at the time when women are vaccinated. One model sought to answer this question, and they found that 50% of women acquired this causal HPV infection by age 20.6 years, and by age 30, 75% of women who go on to develop cervical cancer would have already acquired this infection. HPV 16 infections were acquired at an early age and other types. So they stated that assuming a 95% efficacy against HPV 16 and 18 infections, the reduction in the lifetime risk of cervical cancer varied from 55% on average for women vaccinated at age 9 to about 6% in women vaccinated at age 45. Let's look at overall survival in cervical cancer. So when detected at an early stage, the 5-year survival rate for people with cervical cancer is about 92%. US data shows that about 44% of people with cervical cancer are diagnosed at an early stage. Anecdotally, we tend to find a lot of our women presenting at a late stage, but local unpublished data, which was a 10-year review, actually found that 54%, so half our patients actually presented with stage 1 disease. Most of them presented with abnormal bleeding, about 5% presented because of an abnormal pap smear. So if cervical cancer has already spread to surrounding tissues, then the survival decreases. So if it spreads to surrounding lymph nodes, for example, the 5-year survival rate goes down to about 59%. And any distant spread, the survival decreases to about 17%. So the question asked is the mortality increased in cervical cancer in our younger women? So anecdotally, again, we have seen cases of young women presenting with very advanced disease and not doing very well compared to our older women. But the truth is, this is a question of debate, as the impact of age on the prognosis of cervical cancer, the evidence is conflicting. Some evidence suggests that the risk that there's poor survival outcome, that this increases with age because older women are less likely to receive aggressive treatment. They may refuse treatment altogether, not be offered treatment, or because of their comorbidities, they don't do well overall, or they may have more advanced disease. while other studies suggest that younger patients have poor prognosis. One reason for this could be the higher incidence of adenocarcinomas and other more aggressive subtypes in younger patients. So adenocarcinomas, we know, have a worse prognosis when compared to squamous cell cancers. There's about a 10 to 20% reduction in the 5-year overall survival rate when compared to squamous cells. Adenocarcinomas are more likely to have nodal and ovarian involvement as well. And when we look at ovarian involvement, this is important because in our younger patients with cervical cancer, we can offer them ovarian conservation more comfortably if they're at low risk of ovarian cancer, hence reducing the issues that come with menopause. But with adenocarcinomas, we need to be careful because there's a higher link or higher possibility of them having ovarian involvement. We do know that the incidence of adenocarcinomas has been increasing steadily. And adenocarcinomas, unlike squamous, is associated with certain other risk factors such as obesity, which is also on the increase globally, and nulliparity. Smoking, which is a major risk factor for squamous cell cancer, has been found to not be as strongly associated with adenocarcinomas. And HPV type 18 is more strongly correlated with adenocarcinomas than the other types. And as it relates to treatment, adenocarcinomas, one of the reasons they don't do as well is because they have been found to be less radiosensitive than squamous cell cancers. So adenocarcinomas has been looked at in younger women in a study done by Chen et al., which identified about 3,600 women. They found adenocarcinomas again to be more common in women under 40. The 5-year survival rate was lower than that of squamous cell cancers, and it was 66% for adenocarcinomas versus 74% overall for squamous. When looking at the 5-year survival rates by stage, we can see that the survival was higher in women with squamous cell cancer. So for example, for stage 1, about 80% down to 26% for stage 4 for squamous cell versus 75% for stage 1 adenocarcinomas down to 0 for stage 4 disease. And in Jamaica, from that same 10-year review, where 113 cases were identified and 76 cases analyzed, the median age was found to be again 50 and the mean age 49, in keeping with established literature. Most women were actually over 34 and about 10% were under. Histological subtypes, squamous cell cancers predominated, with adenocarcinomas and adenosquamous seen in 8% and 3% respectively. This paper then went on to compare the two groups of women, so those between 18 and 34 and those 35 years and older. Interestingly, no cases of adenocarcinomas or adenosquamous were seen in the younger cohort. All cases were squamous cell in the younger cohort. Also, they found that there was no statistically significant link between 1 and 5-year mortality rate and other parameters such as the age, stage at diagnosis, histological subtype, and treatment modality. But a major limitation, though, was the numbers. And of course, the retrospective studies, we know the issues with data, missing data, and follow-up of patients, and so on. So looking at survival in cervical cancer by age group in the US, we have this 5-year review, which found that overall survival for all stages was about 67% in women, and this survival decreased with age. So in women under 50, where we see about 77%, but then 46% in older women over 65. This paper also found that women over 70, regardless of the stage, were significantly more likely to receive less aggressive treatment or no treatment at all. This study in Japan actually had a similar finding, where survival actually decreased with age. So in women under 30, 86%, down to about 54% in women over 65. And again in France, similar finding with a decreased 5-year survival with increasing age. They found that compared to women under 65, the women over 65 had low performance status, but also had more advanced clinical stage at the time of presentation. And here we see the incidence, 40, 58 group peak, and another peak again at about age 70. And the survival rates being better in women who are under 65, seen here in the solid line, compared to those who are over 75. So from this same study in France, So they thought that the poor prognosis for invasive cervical cancer in elderly women may be influenced by the comorbidities which were mentioned and tumor stage than just by treatment efficacy. But they did find that where there was a difference in treatment, it was those who had radiotherapy done versus those who had surgery. So they found that older women who presented earlier and had surgery done tend to have good outcomes versus those who were then older women with the comorbidities who were then referred for radiotherapy. This Taiwanese study, though, actually has conflicting information to what was discussed in the previous papers. So in this paper, looking at roughly 3,000 women, comparing cervical cancer cases in those under 30 to those 30 and over, found that the women under 30 actually had lower survival overall. They found a higher incidence of non-squamous histology in the younger group, a higher rate of paramutual involvement and distant disease in these women under 30 years. A study looking separately at those cervical cancer in women under 35 now looked at 114 cases in the US. They found that the mean age was 29 years. Most women were Caucasian, 13% Black, 10% Hispanic. Half were married, most patients never smoked. And of course, squamous cell histology dominated overall at 68%, whereas adenocarcinomas were seen in about a quarter of these cases. Interestingly, 5 cases of small cell cancer of the cervix was identified in this cohort, 2 occurring in women under 25 years. And also surprising was that 30% of the cases identified were under 20 years. They found that the 5-year overall survival was about 42%, which was lower than in older cohorts. And when we look at those with localized disease under 35 versus those over 50, it's actually half. So 46% for those under 35 with localized disease versus 87 in women over 50. And it's also half that when we look at regional disease, so 25% survival with regional disease versus 54%. So the question asked from this paper is, could these findings point to a different disease pathway in younger women? They found a high incidence of small cell cancers in this cohort, which I mentioned, 2% versus the background of about 0.6 per 100,000. Another paper by Constanton et al. Also found a high incidence of non-squamous types in younger women as well. So they found about a 2% rate as well of non-squamous, non-adenocarcinoma, non-adenosquamous types as well in that 20 to 24-year cohort. And they also found, like this paper, more advanced disease as well, with more women presenting with stage 2 or more. And again, we see progression-free survival is actually better in the older women versus those who are 25 and under, both progression-free and overall survival from this paper. 30% of cases was mentioned were under 20 years. And the questions asked, was this due to a regional variation in the patient cohort? Could it be due to referral bias because the study was conducted at a tertiary academic center? Or could this finding suggest that there really is a different disease pathway in younger women leading to more aggressive disease due to host or other factors? Or could it be some genetic alteration peculiar to that region where the women were from? Looking for that small cell carcinomas, so is there a link between small cell carcinomas, which were found to be more common in younger women, and HPV? This study by Lee et al. In 2018 identified 30 patients with primary small cell carcinoma of the cervix. They found that 15 of them, half of them actually had coexisting other types of cancers as well as the small cell carcinoma. So they had squamous cell, adenocarcinoma, and also in situ versions of these diseases. HPV DNA was detected in all cases, 100% of these small cell cases, of which 90% of them had HPV type 18, which is in contrast to squamous, where generally we know HPV 16 is what accounts for most cases. The prevalence of HPV infection in small cell carcinoma was higher than squamous and glandular types. In another study looking at those 20 to 29-year cohort, identified 1,800 women with cervical cancer in the UK, and they actually found that the women 2024 had more advanced disease at diagnosis. They had a higher proportion having stage 2 or more, and therefore more of them ended up needing chemotherapy and radiotherapy versus hysterectomy, with a smaller proportion, of course, receiving fertility-sparing treatment because of the more advanced disease. And this is unfortunate because in our young women, you want to be able to offer them fertility-sparing treatment, especially in a 20 to 24 cohort. And also, again, that there was a higher proportion of adenosquamous disease and other rare histological subtypes seen in this group. And again, we see here just highlighting the fact that 20% of them in the 20 to 24 cohort presented with stage 2 or more disease versus 3.8 in 25-year-olds and 7.4 in the 26 to 29 group. A study in Japan was done because of concerns about cervical cancer death rates, which they noted to have been increasing in women under 50 years. So data was analyzed from the cancer registry in Japan, and they looked at 3 groups of women. In women 20 to 29 years, they found that the age-specific mortality rates were increasing, and similarly for women 30 to 49 years, but yet in women over 50 years, the mortality rates were decreasing. And they asked, what could have been accounting, what could be the cause of these interesting findings and these very concerning findings. One of the possibilities or one of the theories was that could this be a result of delayed screening? Apparently, the Japanese government had moved the screening rate age from 20 to 30, but then in response to this, they moved it back from 30 to 20 to see if maybe, they could pick up disease in the younger women. And here we can see, not showing very clearly, but in women 20 to 29, increasing in trend in the mortality, similarly for 30 to 49, but yet decreasing mortality rates in women over 50. So why do some women develop cervical cancer at such a young age? Why do we have such aggressive disease in some of our young women? We have all seen cases of very young patients, 20s, early 20s, who are diagnosed with cervical cancer. But yet we know that progression from the time of infection, transforming infection to progression to cancer should take about 20 to 30 years. So I wanted to just highlight this case of this patient who was diagnosed with cervical cancer at age 17. And she's now thriving, she's doing very well, and is now an advocate for cervical cancer screening. So there are several theories which try to explain why we have cervical cancer developing in such young women. One, could there be a genetic susceptibility? So one of many studies shown here, a Swedish study looking at over 9,000 siblings or half-siblings with cervical cancer or dysplasia, thought that 64% of the cases were attributed to genetics in some way, and about 36% to environmental exposures. There's this thinking theory of rapid onset cervical cancer, where some cervical cancer types are more aggressive and don't follow the traditional path, which usually takes the 20 years to transition. And this could explain, cervical cancer in younger women, and also why a patient may have a pap smear done now, and 3 years later, she has a fungating mass on her cervix. Of course, some of it could be due to limitations in screening at the time. Some of it could be due to adenocarcinomas, which we mentioned aren't as readily detected by traditional screening methods. And also they have found that HPV-18 linked to adenocarcinomas it also has a higher transforming ability than type 16. HPV-18 therefore might be associated with more rapid onset disease. In addition to HPV, it's thought that persons who have rapid onset cervical cancer may differ in some way. So they may have more high risk factors as well, like contraceptive use or cigarette smoking, or just high risk sexual behavior as well. Another theory is that of vertical transmission of HPV. Another very interesting theory. They have found that some infants have HPV-induced lesions at birth, such as laryngeal and anogenital lesions. They have detected HPV DNA in the male and female reproductive tract from sperm cells, semen, in the endometrium, in the ovaries. They have detected HPV DNA in amniotic fluid and the placenta and umbilical cord. And it's thought that transplacental infection of HPV can occur from the maternal genital tract, in addition to several other mechanisms. So the increased rate of there's been noted to be an increased rate of HPV detection among newborns who are delivered vaginally versus those delivered by C-section, almost 2 times in those delivered vaginally. So we know it's noted that about 80% of neonates born to women with genital HPV have HPV DNA detected in the nasopharyngeal aspirator mucosa. Among infants who are positive for HPV-16 at birth, HPV DNA could still be detected in about 60% of them at 6 months and 10% of them at 3 years. However, despite the high prevalence of HPV detection, the clinical disease does remain uncommon. So, for example, recurrent laryngeal papillomatosis, thought to be the links to HPV 6 and 11, is actually rare, about 2 to 4 per 100,000 infants. But the questions arise, could this be a possible route of young women developing cervical cancer? So in conclusion, there's conflicting evidence on the impact of age and survival in cervical cancer. We do know that adenocarcinomas and more aggressive histological subtypes are seen more commonly in young women. HPV 16 is the most common type identified in cervical cancer overall, but HPV 18 is more strongly associated with adenocarcinomas. We know that the incidence of adenocarcinomas is increasing and that traditional screening methods with cytology does not readily detect adenocarcinomas, and HPV testing will be more effective in identifying especially early cases of adenocarcinomas. We need more local data on survival by age in cervical cancer, as this does have implications on when we initiate screening in our women, the type of screening used, HPV testing versus cytology, and how often we screen our women, especially with this possibility of rapid onset cervical cancer. It also has implications on how we counsel patients or young patients interested in fertility sparing procedures, if it is that they'll be put at a disadvantage if young women have more aggressive disease. So it's something that we really need some more data on. So it was a pleasure preparing this presentation, and I thank you for your attention, and I'm welcome for any questions.
Thank you again, Dr. Natalie Medley, for your presentation. And so far we have seen we have acquired information with respect to screening as it relates to also inspection with acetic acid, pap smears, which are both conventional and liquid-based, and moving forward with the new guidelines as it relates to primary HPV testing and co-testing. So it'll be interesting after this, with the continued discourse, to see how well this is applicable in our situation, especially as it relates to self-testing or physician-guided testing. Our next presenter, Dr. Anna K. Taylor Christmas. She is also a consultant gynecologic oncologist from the Victoria Jubilee Hospital, and she will be presenting today on cervical cancer landscape in Jamaica.
Good morning, everybody. I am Dr. Anna K. Taylor Christmas, and today I'll be presenting on the cervical cancer landscape in Jamaica. During this presentation, we will be looking at the status of cervical cancer in Jamaica, local statistics for gynecologic oncology through the Victoria Jubilee Hospital outpatient department and our operative list, the local statistics, some of them for radiation oncology through the Kingston Public Hospital, and the economic costs of cervical cancer. We're going to start by looking at the national and global statistics provided by the World Health Organization International Agency for Research on Cancer, GloboCan 2022. In terms of absolute numbers, there was a decrease in the number of new cases reported from 2018 to 2022, and cervical cancer is seen here in orange, moving from 486 in 2018 down to 376 in 2022. And this likely reflects some of the positive effects of screening and public health education by the Ministry of Health. Compared to other cancers in females, cervical cancer accounts for 1 in 10 of all new cancer cases in women and follows endometrial cancer as the second most common gynecological cancer. This reflects population shifts in diseases linked to lifestyle and obesity-related factors. The peak incidence in Jamaica is between the ages of 50 to 54 years, as Dr. Medley just discussed. Despite being third in incidence for women, it has the second highest mortality for female cancers in Jamaica, following breast cancer. It therefore has the highest mortality of all the gynecologic cancers, making it a public health urgency. And so here on this chart, we see that breast cancer is here in absolute numbers of mortality in females in 2022, with an incidence of about 31% for mortality, followed by cancer of the cervix at almost 11%, and then colorectal cancer here at 9%, and then the other two, lung and uterine cancer at almost 7% each. These statistics are especially alarming in light of the primary and secondary preventative measures that have been available for decades, as discussed by Dr. Mitchell earlier, and reflects gaps in our screening, early detection, and public health education and action. There are some positives, however, as the age standardized mortality rate seen here for Jamaica in red on the chart fell to 12.4 in 2022, down from 14.9 in 2011, reflecting the improvements in screening, prevention, and early detection and education programs being undertaken by the Ministry of Health. As Dr. Medley just discussed, deaths from cervical cancer increase consistently with age from 30 years upwards for our local statistics. So how do we compare to the rest of the Caribbean? In absolute numbers, Jamaica makes up, seen here in this green section of the chart, makes up about 40% of the cervical cancer cases from the Caribbean when compared to Barbados, Bahamas, Suriname, Guyana, and Trinidad and Tobago. And this is not surprising as we have a much larger population than those other countries. And the same goes for absolute numbers in mortality, where we make up about 45% of the deaths from cervical cancer, a total number of 236 patients in 2022. When the larger countries of the Dominican Republic and Haiti are included, Jamaica's contribution to the mortality numbers falls to 14%, as they have a much larger population than our own at 11 million or over 11 million people each. And so the Dominican Republic had 622 deaths, or almost 40% of the mortality for cervical cancer, and Haiti had 451 deaths compared to our 236. The age standardized rates give a better comparative picture by equalizing the variables of age distribution and the sizes of different populations in the Caribbean. So this graph now shows Jamaica with the third highest incidence here in blue, behind Suriname and Guyana. When it comes to mortality, Guyana has the highest rate in the Caribbean at 14.9 per 100,000 females, and followed by Belize at 13, and then Jamaica and Suriname each with 12.4 per 100,000 females. For our global comparison, we look at Australia, which is one of the first countries to begin routine vaccination for HPV in girls, combined with a robust national screening program. In 2021, 851 new cases of cervical cancer were diagnosed in women in Australia, and in 2020, 209 women died from the disease. Remember the numbers for Jamaica, there were 376 new cases and 236 deaths. So we had more deaths than Australia had. And since Australia's population is 26 million, the actual mortality rate is 1.5 per 100,000 females compared to our 12.4, 8 times less than that of Jamaica. The mortality rate in the United States, for a closer geographic comparison, is 2.2 per 100,000. And this just shows that we have some work to do to bring our mortality rates from cervical cancer down. Now we move on to looking at some local statistics, which I retrieved from the clinics at the Victoria Jubilee and Kingston Public Hospital that treat patients with cervical cancer. The time frame will be the first third of the year, comparing 2024 with 2023 in some instances. Unfortunately, the data collection was limited by time, preventing me from reviewing a full 12-month period, but the trends are still represented in the data, which will be shown. So this pie chart shows the pathology of new patients referred to our clinic, and unfortunately, a large proportion of the diagnoses were undocumented, seen here in green. The other slices of the pie are blue for cervical pathology, pink for endometrial hair, yellow for ovarian, dark blue for vulval, and red for other malignancies, which includes things like gestational trophoblastic neoplasia, vaginal cancer, sarcomas, other rare tumors, and patients with breast cancer who are referred for risk reduction or adjuvant therapy. From the data that was available, 33% of our new patients had a cervical pathology, followed by endometrial abnormalities, ovarian pathology, vulval pathology, and then other diagnoses. Although nationally, the absolute number incidence of endometrial cancer at about 13% is higher than cervical cancer, which is at 10%, our clinic has always had a higher number of cervical pathology referrals. And this could be because general gynecologists still manage early stage endometrial cancer, and so these cases may be referred less often. The next slide shows our statistics for new patients in 2022 and reflects a similar distribution, showing that we have maintained a higher number of cervical cancer referrals seen here over the years compared to endometrial cancer. The trends have remained the same between 2023 and 2024, with similar numbers of new patients seen over the time, and 2024 is in the front in blue, 2023 in the back in pink. So we have a similar number of new patients seen over the time and a similar distribution of pathology over the 2 years. This breakdown gives some more information on the stage that the patients present at. First, 2024 in blue, and then 2023 in pink. Again, unfortunately, a large number were undocumented, but we did get some patients with carcinoma in situ and stage 1. But the majority of patients presented to us at stage 2, 3, and 4. A few of our patients were also post-treatment after either receiving chemotherapy, radiation, or surgery, and then needing further care. Finally, I'll highlight the patients who have immunocompromising comorbidities, in particular HIV. They represented at least 13% of the patients with cervical pathology in the first part of 2023 and at least 5% in 2024. And this patient population is at very high risk of high-grade dysplasia and accelerated development of invasive carcinoma, requiring very frequent screening and close follow-up of abnormalities. And so this still remains a significant area for public health policy today, and we should always remember this category of patients when we're crafting any health policies for cervical cancer. Here, I've extracted the cases of invasive cervical cancer to show the distribution of stages for 2024 and 2023. Unfortunately, as you can see here, most of our patients are still presenting to us late after stage 1, where surgery is no longer an option. We have limited radiation resources currently, which are shared amongst all patients with cancer, not just cervical cancer patients. So this may lead to delays and further impact the disease course for our patients. Again, it emphasizes the work that we have to do in primary prevention, screening, and early detection to improve our patient outcomes. Surgery for cervical pathology is also contributing to a large portion of our surgical lists. In many high-income countries, cervical cancer rates are falling while endometrial cancer rates are increasing, likely due to its link with lifestyle-related factors and obesity, and improved screening methods and early detection and treatment for cervical abnormalities. In those countries, the majority of their lists have cases of endometrial cancer, followed by ovarian cancers and then other less common tumors. We can see that for 2024 here in blue, there were slightly more surgeries for endometrial pathologies, followed by a similar number for cervical and ovarian, and then lastly, vulval and other pathologies. And the others include diagnoses such as vaginal dysplasia, sarcomas, and other more rare tumors. In the first part of 2023, there were more surgeries for cervical pathologies, with the remaining diagnoses following a similar trend as 2024. I'm going to look at the age distribution for the patients with cervical pathology that we did surgery on, and I'll focus on 2024 in blue here because the data set is more complete. Remembering that the peak incidence for Jamaica is age 50 to 54 years, we see an equal number in the 41 to 50 and the 51 to 60 age groups, which account for the majority of our surgical patients, which is in keeping with the data that Dr. Medley had presented for our national averages. The mean age for 2024 was 46.7, and for 2023, a similar 48.4. The youngest age was the same for 2023 and 2024 at 26 years, and the oldest was similar at 69 and 68 years for 2024 and 2023, respectively. There were no surgical patients in the 15 to 20 age group. Of note, however, in our general clinic, we did see patients as young as 20 years presenting with a locally advanced aggressive cancer that was not a rare histologic subtype, although not surgically managed and so not represented on this chart. Looking at the graph again, we are seeing younger patients in the 21 to 25 and 31 to 40 age group, perhaps highlighting a concerning trend of younger patients presenting with invasive cancer that we have been noting, as Dr. Medley had alluded to earlier. This is definitely something that requires more research and investigation to identify the potential risk factors driving the development of invasive cancer in our younger patient population in Jamaica. Breaking down the actual surgical procedures that were done, they're split into two main groups. Those with carcinoma in situ or stage 0 seen here on the left in this column, and those with invasive cervical cancer on the right. In 2024, for patients with carcinoma in situ, all received cone biopsies, which are both diagnostic and therapeutic. 2023 was similar for those patients, although there were slightly more cone biopsies done and one patient who had examination and biopsy. For patients with invasive cancer on the right, in the first third of 2024, most of them seen here in the top part of the column had radical hysterectomies with curative intent, and all of them were stage 1B. One had a hysterectomy due to being stage 1A, and two had cone biopsies to assist with proper staging. In 2023, we did less radical hysterectomy, so we did two for patients who were stage 1B and two simple hysterectomies, one at stage 1A and one post chemotherapy for patients who was stage 2 as a salvage procedure. And we also had two other patients who had biopsy to assist with staging. So having more patients presenting with stage 0 and early stage cancer amenable to surgery is a positive, reflecting better screening and early detection capabilities. And we will wait on the full data for 2024 to see if this continues to bear out for the rest of the year. For our patients who were too advanced for surgery, they were referred to the Kingston Public Hospital for radiation therapy, whether curative or palliative. Of note, the data reflects a 12-month time period, not just 4, and not all the patients treated there were referred from VJH, so the numbers may differ. External beam radiation was administered to 50 patients with cervical cancer. And of those patients in that time frame, 32 also received brachytherapy. For the patients who received brachytherapy, most of them were in the 51 to 60 age group, which is in keeping with our national statistics and what is expected, followed by the 41 to 50 age group. There were, however, a few young patients in the 31 to 40 age group who accounted for approximately 9%, almost 10% of the patients treated with brachytherapy. Comparing the age distributions of surgical versus brachytherapy patients, we are seeing more young patients in the surgical group here, 30 and under, but an otherwise similar spread for those over 40 years, which is expected. Again, there were no patients over 70 recorded, which validates our screening protocol age range that we have developed for Jamaica. And we didn't treat any patients who were 20 and under either. Again, validating our screening age range. So every disease has an economic impact on the individual, her home, her community, and the country as a whole. Disparities also exist for those in separate economic bands. Healthcare treatments and a more active lifestyle are all more readily available to people with higher incomes. Problems with health insurance and other financial constraints are the root causes of restrictions for those in lower socioeconomic groups. Data on the direct economic cost in Jamaica is extremely limited, and so most statistics are available from other countries, but I'm going to try and see if we can extrapolate that and put it into a Jamaican context. For this survey that was done in the United States in 2020, it was found that most cervical cancer patients were employed and they were equally distributed amongst the socioeconomic groups. So 1/3 each were poor, middle income, or high income. 12% of them were uninsured, and 55% of them accessed private insurance only, while the rest, remaining percentages, used public health care. Of course, in our context, we know that a high percentage of Jamaicans are uninsured, and so our numbers accessing private care would, I expect, to be a lot lower than this. Although we have no hard data, anecdotally, we also find that most of our patients are employed and in their peak earning potential years due to their ages at presentation. In this review done in Uganda by Dow et al., over 90% of participants in both groups reported paying out of pocket for cervical cancer. 15 of the participants stopped treatment because they could not afford it, but most of them completed their treatment. Women of a lower socioeconomic group were significantly more likely to report borrowing money and selling possessions to pay for care, and both groups reported a decrease in the amount of time they spent caring for their children since their cervical cancer diagnosis. And patients accessing care in our public health system will also encounter similar economic difficulties. An analysis of direct and indirect economic costs in the United States in 2015 by Nwanko et al. Found that for direct healthcare costs related to admission to hospital, outpatient services, admission for therapy, medication, surgical fees, chemotherapy, and radiation, the cost came up to over $1 billion for cervical cancer care in 2015. The indirect cost from lost productivity of the patients was over $14 million. The indirect cost from early death and loss of that earning potential for the patients was over $2 billion with a B US, and the total cost in all, direct and indirect, for cervical cancer in 2015 was over $3 billion US. A systematic review of the economic cost of cervical cancer in the United States done by Shaw et al. In 2018 found that the mean cost the first year after diagnosis was $50,800. That's approximately almost 6 million Jamaican dollars, and that was in 2015. The average total cost of 6 cycles of cisplatin and paclitaxel, which Dr. Mitchell had discussed as the standard chemotherapeutic agents used to treat cervical cancer, was about $33,000 per patient. When you added bevacizumab, which is a vascular inhibitor, to either cisplatin with paclitaxel or topetacan with paclitaxel, it increased the mean total cost per patient to $97,000 or $109,000 respectively. So that is about 12.7 million Jamaican dollars when converted if you have to add bevacizumab or other immunotherapeutic agents to their care. And although the cost may not be exactly the same in Jamaica, maybe a little bit less, it still costs millions of dollars to add these agents when there's advanced cancer on board. So for some local context for the cost of a course of chemoradiation privately is about 3 million Jamaican dollars. If we add second-line chemotherapeutic agents, vascular agents, or immunotherapy, as discussed in the previous slides, it's expensive. It often has to be sourced privately with very prohibitive costs per treatment course if not covered by the patient's insurance. And for comparison, the preventative measures, a pap smear is about $1,500 to $1,800, the basic lab cost. A liquid-based cytology is about $5,000. The HPV vaccine is about $19,000 per dose, and it's free for certain age females in the public system. The Harris HPV screen is about $19,000 at the lab. So we can see where the cheaper costs are with regards to cervical cancer. Cervical cancer is associated with significant economic burden, activity limitations, and quality of life impairment. It has a social impact on patients in terms of social discrimination, loss of body image, loss of sexual functioning, and loss of femininity. It also has an economic impact in terms of loss of income, loss financial distress due to medical and non-medical expenditures, and that includes transportation to clinics for follow-up visits, to hospital for treatment, whether surgery, chemotherapy, radiation, accommodation for these visits, and childcare expenses that may be associated with these treatments protocols designed for them, or care for other relatives that they may have care of, as well as work and employment challenges. In fact, we have patients who exhaust all their leave and have to take no pay leave and lose income, or who lose their jobs because of the frequent times off required from work. In summary, it's clear to see that the investment has to be made in improving screening, prevention, and early detection efforts to prevent the high socioeconomic burden that cervical cancer presents to us as a country in the hundreds of millions of dollars annually, if not more. So where do we want to be? Dr. Davidson is going to speak in detail about the Jamaican response to the WHO global objectives, and this is where our energy should now lie as individuals, as patients, as practitioners, as anyone involved in healthcare in the approach to cervical cancer. Our aim is to eliminate cervical cancer as a public health problem and significantly decrease the morbidity, loss of economic power, and mortality associated with the disease. These are the Sustainable Development Goals the WHO would like to achieve, with measurable markers to be assessed in 2030. And for cervical cancer, achieving our goal will also help with some of the other SDGs, including the elimination of poverty, ensuring good health and well-being for all, improving gender equality, and reduced inequalities overall. We hope that as more active programs are implemented, we will have better and better statistics to present for the sake of our fellow Jamaicans, and that we will achieve our 2030 goal of reducing cervical cancer deaths by more than 30%. So in summary, our numbers for incidence and mortality are still too high. The possible trend of younger patients with invasive cancer is concerning and needs to be investigated further. Cervical cancer is a significant economic and social burden on Jamaica, and we need to invest more time and resources and get all stakeholders on board to achieve our goal for cervical cancer elimination. Thank you.
Thank you again, Dr. Anarchy Taylor Christmas, for a presentation. So Dr. Barnes will be updating us on chemotherapy for the cervical cancer patient. Dr. Tony Barnes, a consultant hematologist and medical oncologist, also works out of the Hope Institute. She's a graduate of the University of the West Indies. She's been working as a senior registrar also at the Kingston Public Hospital, and it is her goal and dream to advance cancer treatment in Jamaica through research and education. She wishes to pursue further studies in the management of acute leukemia, and one day hopes, and I believe will, set up a bone marrow transplant program in the island. So without further ado, Dr. Tony Barnes will be the last presenter before, after which we will be doing a 5-minute break. Dr. Barnes?
Good day, everyone. I am Tony Barnes. I'm a hematologist and medical oncologist working at the Hope Institute Hospital, and today I will be presenting on chemotherapy update for the cervical cancer patient. So the factors that guide your decision-making process for patients with any kinds of cancer would be the histology as well as the stage of the cancer. Pertaining to the histology, The most common histologic types of cervical cancer are squamous cell carcinoma and adenocarcinoma, and cancers can be either HPV associated or HPV independent. The distribution of these histologic subtypes in the United States are squamous cell carcinoma being 75 to 80% of the distribution, and adenocarcinoma, including adenosquamous, being 20 to 25%. The other histological subtypes, such as neuroendocrine, rhabdomyosarcoma, primary cervical, cervical sarcoma, only take up about 1 to 2% of the total distribution of these cancers. So early stage cervical cancer is where I will start, although the majority of systemic therapy is done in the metastatic patient population, but there is some use of chemotherapy early on. Early stage cervical cancer refers to cancers that are FIGO stage 1A, 1B1, and 1B2, with stage 1A being invasive carcinoma that can only be diagnosed microscopically. There's no grossly identifiable tissue. For stages 1B1 and 1B2, these are grossly identifiable lesions and are confined to less than or equal to 4 centimeters in greatest dimension. Any larger than that would be considered locally advanced. And you can see here in the summary slide, we would stop with locally advanced right here at 1B2 disease. The treatment of early stage cervical cancer primarily is either radiotherapy or surgery. And surgery is typically reserved for early stage disease, particularly in women who would stages 1B3 to 4A. Chemoradiation can also be used in early stage cervical cancer for patients who are not candidates for surgery for whatever reason. Although few studies have assessed treatment specifically for adenocarcinomas, they are typically treated in a similar manner to squamous cell carcinomas. Now, the adjuvant treatment in early cervical cancer has been considered. An adjuvant treatment is any treatment that is given after surgery. We're used to talking about adjuvant chemotherapy, but you can have adjuvant radiotherapy or adjuvant chemoradiotherapy. The indications for adjuvant therapy would be patients who have early stage cervical cancer treated with a primary surgical approach. Adjuvant therapy should be administered if there are adverse pathological findings or pathological findings that suggest that the patients are at high risk for tumor recurrence. Peters criteria is what is used to determine which patients are high risk at the time of histological review of the tumor specimen post-surgery. And the criteria that show there is high-risk disease include patients who have positive surgical margins, patients who have pathologically confirmed involvement of the pelvic nodes, and patients who have microscopic involvement of the parametrium. Adjuvant chemoradiation is usually recommended for patients who are at high risk for recurrence. The drugs that are used for this adjuvant chemoradiation usually include a platinum-based therapy with cisplatin, sometimes in combination with 5-fluorouracil. Single-agent cisplatin, however, has been used and is associated with less morbidity than cisplatin and 5-FU in combination. Now, locally advanced cervical cancer refers to patients who have stages 1B3 to 4A disease. 1B3 is tumors that are confined to the cervix but are more than 4 centimeters in greatest dimension. Stage 2 is the tumors that are beyond the uterus but don't go as far as the pelvic wall or the lower third of the vagina. Stage 3 is the tumors that extend to the pelvic sidewall and possibly involve the lower third of the vagina, or those tumors that cause hydronephrosis, or those that involve the pelvis or para-aortic lymph nodes. And then you have 4A, which is distinctly different from 4B, as 4A invades the mucosa of the bladder or rectum, or extends beyond the true pelvis, but is not considered to be distant metastatic disease. And again, we have our summary of the FIGO classification of those tumors. So locally advanced would then take up all of this and go to 4A just before 4B, which is metastatic and spread to distant organs. Now, the management of locally advanced cervical cancer is important because these patients have a higher rate of recurrence and worse survival than those who have early stage disease. After surgery alone, the rate of relapse is at least 30%, and the 5-year survival rates range from 80% for patients who have stage 1B and 30% for patients who have stage 3. And this data is for squamous cell carcinoma. Now, primary surgery is not usually offered for patients with locally advanced cervical cancer, as it is not thought to be curative in these patients. And patients who receive upfront surgery usually then require adjuvant treatment of some kind, which results in a high incidence of morbidity. Chemoradiotherapy is a treatment of choice, and the agent that is used as a radiosensitizer is usually single agent cisplatin. But as we spoke about before, cisplatin plus 5-fluorouracil can be used. The regimen that is preferred, however, is weekly cisplatin during radiotherapy. And the weekly cisplatin dose is 40 milligrams per meter squared, which is much lower than the 3-weekly dose, thus causing there to be less toxicity. Now, single agent cisplatin administered with radiotherapy had similar outcomes to cisplatin plus 5-FU with a better toxicity profile. Patients were more likely to complete their treatments if they received single agent treatment versus the double agents or combination. They had less serious toxicity, and they had a similar complete response rate. So there was no real disadvantage to offering the patients single agent therapy. So that is a modality of choice. Cisplatin and gemcitabine have also been explored, but there is a significant risk of adverse events. Now, there has also been a discussion about whether adjuvant chemotherapy would be helpful in these patients after chemoradiation, and the Outback trial attempted to look at this population of patients. They randomized patients into receiving concurrent chemoradiation only versus receiving current chemoradiation plus adjuvant chemotherapy with carboplatin and cisplatin and paclitaxel. The primary endpoint for this trial was overall survival, and they also looked at endpoints like progression-free survival and the frequency of adverse events. What they found was that the overall survival was not significantly different between the two groups, 71% for those receiving chemoradiotherapy and 72% for those who received chemoradiotherapy plus adjuvant therapy. And it was not statistically significant. For progression-free survival, similarly, you have 61% and 63%, but no statistically significant difference. So there's limited evidence to benefit to justify the additional risk of toxicity. So no adjuvant chemotherapy after chemoradiation is recommended. Now, neoadjuvant and induction chemotherapy are often confused. And both of them have been reviewed in this population of patients. Neoadjuvant chemotherapy refers to pre-surgery chemotherapy, whereas induction chemotherapy refers to pre-radiation chemotherapy. Now, neoadjuvant chemotherapy in this population of patients is sometimes used where radiotherapy is not available, and that is a common issue in our country and in our healthcare system. Sometimes neoadjuvant chemotherapy followed by surgery may be the only option we have to treat somebody with cervical cancer, depending on the fact that, sometimes the machine breaks down or sometimes there's affordability issues if private radiation is the only choice. And so sometimes neoadjuvant chemotherapy to try to shrink the tumor so the patient can get successful surgery is the only option that we have, or is an option that we might need to use if we think that the patient will have an undue delay in starting their radiotherapy, and that undue delay is more than 6 weeks. Neoadjuvant chemotherapy prior to definitive surgery unfortunately does not offer an overall survival advantage relative to primary chemoradiation. And in some randomized trials, giving neoadjuvant chemotherapy, then surgery is associated with inferior disease-free survival as compared to chemoradiotherapy. So for these patients, every effort should be made to provide access to definitive chemoradiation, given the fact that they are potentially curable. Outside of a clinical trial, none of the societies like NCCN, ESCO, ESTRO, none of their guidelines recommend the use of neoadjuvant chemotherapy. But we do have to bear in mind that these countries that produce these guidelines don't have the availability issues that we have. So it would be good if we had our own guidelines to assist in management of these cases, because although neoadjuvant chemotherapy is not a perfect alternative, there's no survival disadvantage to the lack of radiotherapy when we can offer them neoadjuvant chemotherapy and then timely surgery, as long as the patient responds to the chemotherapy. Now, induction chemotherapy, which we said was chemotherapy given prior to radiotherapy, was looked at in the recent Interlace trial, which was presented at ESMO in 2023. And what it aimed to look at was patients who received induction chemotherapy who had locally advanced cancer. This population of patients with locally advanced cancer was randomized to receive induction chemo with carboplatin and paclitaxel, then chemoradiotherapy with cisplatin versus chemoradiotherapy alone. And the outcome of this trial showed that overall survival was improved in patients who received induction chemotherapy and chemoradiotherapy, as opposed to patients who received chemoradiotherapy alone. There was also an improvement in progression-free survival in patients who got induction chemotherapy as opposed to chemoradiotherapy alone. So induction chemotherapy, although it is not yet in clinical guidelines, seems to be perhaps a practice-changing recommendation for the future. Now, immune checkpoint inhibitors are a big part of cancer treatment recently, commonly called immunotherapy. We have drugs that modulate the immune system in order to fight the cancer. Just to remind you of what these drugs do, the T cells express PD-1 receptors, and these PD-1 receptors bind to PD-L1. Now, generally, the PD-1 receptor is looking for any foreign antigen, any foreign invaders like the tumor cells that do not have a ligand on them. And so when the T cell encounters these cells with no ligands, the cells are destroyed. But what some of the tumor cells have evolved to have is PD-L1 on their surface, which then binds to the T cell and causes the T cell not to recognize them as foreign. So what we have now in our arsenal is immunotherapy with pembrolizumab and other checkpoint inhibitors, which can inhibit the interaction between the tumor and the PD-1 receptor. And so the T cell can recognize the tumor as foreign and the tumor will then be destroyed. Pembrolizumab is a PD-1 inhibitor, but you also have PD-L1 inhibitors such as atezolizumab. Now, this study, the Keynote A18, was also presented at ESMO 2023, and they looked at patients who had locally advanced cervical cancer and randomized them to receive either standard of care, which was chemoradiotherapy, versus standard of care chemoradiotherapy plus pembrolizumab, followed by pembrolizumab maintenance. What they found was that there was an improvement in the progression-free survival for patients who received pembrolizumab, but the overall survival data is not yet mature, and so we'll have to await their long-term results to see whether or not the survival outcomes are favorable. So metastatic and recurrent cervical cancer is where most of the systemic regimens reside. For metastatic disease, patients who present with metastatic disease, which is stage 4B, primary treatment is often a platinum-containing chemotherapy. In these situations, we can also offer patients individualized external beam radiotherapy for control of pelvic disease, control of pelvic pain, bleeding, and other symptoms. Although it is uncommon at initial diagnosis, metastatic disease will develop in 15 to 60% of women who have cervical cancer, and this is usually within the first 2 years of them completing primary treatment. Patients who develop distant metastases, either at their initial presentation or at relapse, are rarely curable. Patients who may benefit from aggressive management of metastatic disease are those usually who have oligometastatic disease, which can be resected and usually include nodal, lung, liver, or bone metastases. Following local therapy, adjuvant chemotherapy can be considered. And for most other patients who have distant metastases, an appropriate approach is clinical trial or going straight to systemic chemotherapy or best supportive care if the patient has a poor performance status. Cisplatin has long been considered the most effective agent for metastatic cervical cancer, but most patients who develop metastatic disease have already received concurrent cisplatin and radiotherapy as their primary treatment option, and so they may no longer be sensitive to single agent platinum therapy. Therefore, we have to usually offer them now a combination chemotherapy regimen. The number one recommended regimen would be cisplatin in combination with paclitaxel and the addition of the anti-VEGF bevacizumab. We can also offer them cisplatin and paclitaxel dual therapy or cisplatin and topotecan. And there are several other combinations that are available, but those are the most highly recommended ones. Now, to look at combination therapies versus single agent therapies, studies have been done to look at using multiple drugs versus one, because usually in metastatic disease, you try to be less aggressive so that the patient doesn't have too many side effects and they have a good quality of life. But for cervical cancer, it has been found that giving the two-drug combination improves the patient's response rate to treatment, improves progression-free survival, and improves their quality of life, despite the fact that two drugs are being given rather than one. The choice of combination therapy has been looked at by a GOG trial, and they looked at carboplatin and paclitaxel versus cisplatin and paclitaxel. And I think that most of us that treat patients with cervical cancer would most likely recognize carboplatin and paclitaxel as the most commonly used chemotherapy regimen. It is used often because of its ease of administration and its good tolerability. Carboplatin and paclitaxel actually is non-inferior to cisplatin and paclitaxel when you look at it in terms of median overall survival. And in patients who have hospital admissions, the non-hospitalization periods are significantly longer for patients receiving carboplatin and paclitaxel, most likely because of the decrease in adverse events because of the omission of the cisplatin, which can be highly nephrotoxic. Unfortunately, though, among patients who had not received prior cisplatin, the overall survival data shows that for carboplatin and paclitaxel, the overall survival is less than cisplatin and paclitaxel. So if you're platinum naive, it is probably better to receive cisplatin and paclitaxel. And if you received prior cisplatin therapy, it is probably better to receive carboplatin and cisplatin. If you can tolerate the side effects of cisplatin, then that might be a better choice. Now, single agent therapy still is used because a lot of the time our patients have comorbidities or have a poor performance score, maybe not able to tolerate two agents, and you have to offer them one. And for those patients, cisplatin is generally regarded as the most active agent, and it is recommended as the first-line single agent option with a response rate of 20 to 30%. Occasionally, patients will have a complete response, and the overall survival with cisplatin, not very long, about 6 to 9 months. There are other very tolerable and efficacious first-line single-agent chemotherapy options for patients who can't tolerate cisplatin, and those include carboplatin and paclitaxel as single agents. Bevacizumab, an anti-VEGF that I briefly mentioned before, was looked at in the GOG 240 trial, where patients with metastatic, persistent, or recurrent cervical cancer were offered chemotherapy by itself or chemotherapy with bevacizumab. And what the trial showed was that patients who received chemotherapy plus bevacizumab had an improvement in overall survival versus chemotherapy alone. The overall survival, particularly in patients who didn't receive prior radiotherapy, was higher in both groups. I think because the radiotherapy sometimes has these long-term side effects. There was a significant improvement in progression-free survival and a significant improvement in the overall response rate. The adverse effects seen with the bevacizumab, though, were hypertension, fistulae, neutropenia, and thrombosis. Checkpoint inhibitors again come back in metastatic disease. So previously I had discussed briefly the pembrolizumab being an anti-PD-1, and now we have atezolizumab, which is an anti-PD-L1. So the pembrolizumab works at the level of the T cell against the PD-1 on the T cell, and the atezolizumab works at the end of the tumor cell because it blocks the ligand. And either way, it blocks this interaction here between the T cell and the tumor cell, so the tumor cell can no longer escape detection. Atezolizumab is very recently now being recommended in terms of clinical trials, not on guidelines, but clinical trials, as an option to be used irrespective of PD-L1 status. So tests for PD-L1 status should be done in all the patients who have metastatic disease to assess the levels, but atezolizumab can be used regardless of these levels. And the BEAT-CC trial showed that there was an improved overall survival when atezolizumab is given with chemotherapy and bevacizumab versus chemotherapy and bevacizumab alone. Pembrolizumab is offered to patients who have PD-L1 positive disease only, and it also showed an improved overall survival in these patients versus chemotherapy and bevacizumab alone. Now, tisotumab vedotin is an anti-tissue factor directed antibody drug conjugate. It is very new, and the INNOVA-TV 204 trial is a phase 2 trial that looked only at response rate and looked at patients who had previously been treated for cervical cancer. So these patients were recurrent and perhaps on their second or third line of therapy. And it showed an overall response rate of 24%. It is also being studied as an adjunct to treatment with pembrolizumab or chemotherapy with carboplatin. Trastuzumab deruxtecan is a drug that was also presented at ESMO 2023, and it is an anti-HER2 agent. And what this study did was essentially took patients with varying solid tumors, cervical, endometrial, ovarian, pancreatic, and so on, and looked at their HER2 expression. And any of those tumors that were HER2 expressing, they gave those patients Enhertu, and it did have encouraging overall response rates for numerous tumors, but cervical, endometrial, and ovarian were the highest. So it seems to have very good response in gynae tumors. So this is also not guideline-directed therapy just yet, but it is an option in somebody who has been through multiple lines of therapy and you're looking for something else that you can offer her. So there are other rarer tumors, which I touched on before, like clear cell tumors, neuroendocrine tumors, and these account for about 2% of cervical cancers in the United States. Because they are so rare, there are no prospective trials that we can use to inform their treatment. As a result, we treat them with platinum-based therapy as extrapolated from the treatment of other types of cervical cancer, the squamous cell and adenocarcinoma, as well as small cell lung cancer, which is also treated with platinum-based therapy. Unfortunately, these patients are typically younger. They have very aggressive disease, they're more likely to metastasize, and they have poor survival outcomes. This is the most recent NCCN guideline showing systemic therapy for cervical cancer. And for metastatic disease, as you can see, they recommend PD-L1 testing here because the first thing they have put up is for PD-L1 positive tumors, the pembrolizumab, the cisplatin paclitaxel, which we spoke about, with or without bevacizumab. They also have the option of giving cisplatin, paclitaxel, and bevacizumab. Atezolizumab is not here yet, but perhaps throughout the year when they update their guidelines or after more data comes out, they may add that as a recommended regimen. For second line and subsequent therapies, just as we had discussed before, we have tisotumab, which is the anti-TIGIT factor. We have the bevacizumab. We also have here the famtrastuzumab deruxtecan for HER2 positive tumors. And then also for future molecular testing, we have anti-RET therapy, anti-NTRK therapy. And so molecular testing is going to become more and more important as we find more targets for different types of cancer. So summary for the metastatic disease treatment for patients who are non-surgical candidates and have no expression of PD-L1, we should offer them systemic therapy with platinum, usually cisplatin, plus paclitaxel, plus bevacizumab. And then I put query bevacizumab, query atezolizumab because of the fact that it is very new data, but it most likely will become a recommendation. And then for tumors that express PD-L1, we would recommend giving pembrolizumab plus platinum-based chemo with or without the bevacizumab. As it relates to carboplatin versus cisplatin, carboplatin is a reasonable substitute. It has a more tolerable toxicity profile, especially for patients who are previously treated with cisplatin plus radiation. Molecular profiling and next generation sequencing is becoming the standard because we have all of these attractive molecular targeted therapies. And all patients should have PD-L1 testing because immunotherapy is becoming standard of care. So thank you very much for your attention and have a good day.
Yes, again, very thorough presentation with respect to chemotherapy. One of the challenges that we often see that is in the treatment of patients that come to us, especially with advanced disease. Early stage disease we see that are amenable to surgery. We may do simple hysterectomy, move away from radical hysterectomy in appropriately selected patients. But patients who have advanced disease, especially with limitations of brachytherapy, Dr. Barnes spoke about the different options, especially when chemoradiotherapy is not as readily available with the use of induction therapy with induction therapy, giving chemotherapy prior. And also we're seeing now that the latest and the newest advances where immunotherapy is becoming the standard of care. Again, very expensive treatment, but very interesting to note how far we have come where we have the machinery and the options which are available for the treatment of our patients. So we are actually moving in good time. All right, so our next presentation is going to be that from Dr. Ian Bambury. He's a consultant gynecologic oncologist working from the University of the West Indies. And he's going to speak to us about the silent killer, ovarian cancer. Dr. Bambury.
Hello. Thank you to the Jamaica Cancer Society for inviting me to speak at the St. Elmo Hall Memorial Lecture Series. And today my topic is on ovarian cancer, the silent killer. For this talk, I have nothing to disclose. So just to start with, in terms of the objectives for this talk, I'd like to look briefly at the anatomy of the ovaries, a little bit about the epidemiology, risk factors, how do patients with ovarian cancers present, and how do we manage these patients? And we take a look as well at some of the preventing strategies really to reduce the mortality from ovarian cancer. So the ovaries are these oval-shaped organs, and they're intimately involved in the reproductive career of women. They produce estrogen and progesterone. And when a woman gets to menopause, then these hormones production are reduced. So yes, the ovaries do wonderful things, but at the same time, there are bad things that can happen to the ovaries, such as ovarian cancer. And ovarian cancer is a leading cause of death from gynae malignancy, with a lifetime risk of about 1 in 70, about 2%. And is often called the silent killer. And this is largely because of how late they present. And with that late presentation, the cure rate is minimal. You know, the mortality is very high. So in terms of the epidemiology, 1 in 70 women will develop ovarian cancer. This is development of ovarian cancer in the general population. 1 in 70 will in their lifetime. It's the 5th most common female cancer worldwide, and accounts for 3 to 4% of cancers among women. When we look at the global picture in terms of the cases and deaths, there are over 300,000 new cases of ovarian cancer diagnosed, with just under 300,000 deaths worldwide. And when we look closer to the Caribbean, the incidence is about 4.6 per 100,000, with a mortality rate of 3.2 per 100,000. And when we look at the North American incidence, we're talking about 8.1 per 100,000, with a mortality of 4.1 per 100,000. But let us look at what happens in low and middle income countries, for example, and what are the common cancers that we're seeing. So when we look at this picture to your left, we can still see that cervical cancer is still the leading cause of, in terms of the incidence. And this is followed by uterine cancer and ovarian cancer. But when we now take a look on the other picture on the right, cervical cancer is still a leading cause of death, but note that ovarian cancer is also a significant cause of death in terms of the 3 leading gynae malignancies, and then this is followed by uterine cancer. So a significant burden in terms of ovarian cancer, and its mortality is seen in the low and middle income countries. So let's turn our attention now to some of the ovarian tumor types that are seen. And when we look at this figure to your right, the ovary is made up of a surface epithelium, yes, derived from the Mullerian system, yes. It also has in it, it's called a sex called stromal tissue. And in addition to that, it has what's called a germ cell tissue. Now, the epithelial tissue of the ovary gives rise to the most common type of ovarian cancer, known as the serous tumors. And we tend to see these serous tumors mainly in women in the 6th decade of life, usually in our postmenopausal woman. The germ cell tumors, as we saw earlier, rise in there, these tend to affect the younger population, usually those under the age of 20 years of age. So if you see a young woman with a pelvic mass, we tend to think that germ cell tumor until proven otherwise, compared to that of the older age group, those in the postmenopausal period. We tend to think of this more of an epithelial tumor. And the third class of tumor, now we're talking about primary ovarian cancer here. The third class of tumors in the ovary are those that are derived from the sex called stroma. Tend to see this about the middle age group. So epithelial tumors account for 90% of ovarian neoplasm, and the most common subtype in terms of histology is serous cyst adenocarcinoma. This is followed by a mucinous tumor, mucinous cyst adenocarcinoma, endometrioid, and clear cell. And we rely on our pathologists when they look at these slides, once we submit this tissue, and they will look at the various architecture and is able to give us the different subtypes of ovarian cancer. In terms of our younger population, germ cell tumors, as we mentioned earlier, is the most common type of ovarian cancer, but the most common germ cell tumors are actually benign tumors, and these are what we call our dermoid cyst or mature cystic teratoma. But in terms of the malignant germ cell tumors now, dysgerminoma is the most common type of malignant germ cell tumor in our young patients, and this is followed by immature teratoma and our yolk sac tumors. In that middle age group, the sex called stromal tumors are there, and the most common type of these are called granulosa cell tumors, although we may see a juvenile onset granulosa cell tumor in a younger patient. So if we do see a young premenarchal girl who has a pelvic mass, but then she's demonstrating secondary sexual characteristics earlier than her counterparts, such as a pelvic mass, then we tend to think of this, the likely cause of this is a juvenile granulosa cell tumor. And of course, as it relates to our Sertoli-leaded cell tumors, if you have a woman that demonstrating male-like signs like deep voice, hair growth, male pattern hair growth, and as a pelvic mass, then we think that this is likely to be a Sertoli-leaded cell tumor, but the evaluation will help us further. So let's focus ourselves a little bit here on the common tumor that tends to, as we said, the silent killer, and that is our epithelial tumors. And what are some of the risk factors? Age, so increase in age, as we mentioned, is a disease largely in women in their sixth decade of life. And 60% of women with ovarian cancer are older than 55, and 32% are younger than 55. Probably about less than 10% of women under the age of 40 will have an epithelial cancer, epithelial tumor. But other risk factors include early menarche and late menopause, and nulliparity, not having any children. But there are some women who have a strong family history of breast cancer or colon cancer, ovarian cancer, then that risk increases for that person. And of course, there's a genetic predisposition, those that may have germline mutation in these genes called BRCA1, BRCA1, as well as BRCA2 mutations, and this is seen in about 10 to 15% of patients. Notice that 10% of women with ovarian cancer have a positive family history at heterozygous mutation in the BRCA1 and 2 gene. So if a patient has a mutation in BRCA1, then the risk of developing epithelial ovarian cancer is about 25 to 50%. Note that this is also implicated in breast cancer, with the risk being about 60 to 80% for breast cancer. And for those who may have a mutation in BRCA2, then the risk of developing ovarian cancer is about 10 to 20%. So how do these patients with these tumors present, or postmenopausal women with these epithelial tumor present? Now, the initial spread is clinically occult. A large volume of diseases sometimes present often before we see these patients. So when the horse has actually gone through the gates is when we tend to see these patients. And 78% of ovarian cancer have spread beyond the ovary at the time of diagnosis. So if a woman presents with, a mass in the abdomen, distended abdomen, then we do a few evaluation investigations, baseline CBC, electrolytes, or urea and creatinine. But we also do tumor markers, as a number of these tumors, these epithelial tumors, do secrete tumor markers. One such is our cancer antigen 125, CA125, or the carcinoembryonic antigen that is often seen or common in our mucinous tumors. For the younger group, though, the younger age group that tend to have germ cell tumors, then the tumor markers that is commonly secreted are alpha fetoprotein, beta HCG, and LDH. And for our granulosa cell tumor, the tumor marker that is often expressed is our inhibin. So these are then followed by imaging modalities, right? But imaging modalities such as a transvaginal ultrasound, which is very good in picking up, adnexal masses. But certainly, if there's any doubt about where these adnexal masses are arising from, then an MRI is a good modality in terms of imaging. CT scan, of course, is used in terms of determining the extent of disease once you have a woman that has a pelvic mass. And these imaging modalities, particularly ultrasound, along with our CA125, these can help us to determine whether or not a mass in our postmenopausal woman is this likely to be cancer or not cancer. Because if the index of suspicion for cancer is high based on our risk of malignancy index, then these patients should ideally be referred to a gynecologist for their management. If the CEA is elevated, we have to think, is this cancer of the ovary a primary ovarian cancer, or is this a cancer coming from somewhere else that is spread to the ovaries, such as from our GI tract, the stomach, or the colon? And so as part of the investigation, particularly if the CEA is elevated, we may do an upper GI series, or we may do a lower GI series, such as a colonoscopy. So this is a typical patient. This is a 84-year-old woman, and she presented with a 6 months, a greater than 6 month history of increase in abdominal girth. Notice how extensive her abdomen is. And a CT scan that was performed showed this large pelvic mass, extremely large pelvic mass. And note here that the cancer antigen 125 is 185. The normal in most jurisdictions is actually less than 35. So hers was significantly elevated. Now, the management of these cases usually involve first-line treatment with cytoreductive surgery, debulking surgery. So we're trying to remove all the disease as possible to the point where there's minimal to zero disease left at the end of our surgery. And at the end of the surgery, as we mentioned earlier, majority of our patients with epithelial ovarian cancer do present quite late, usually at stage 3 disease. And so surgery alone is not the end of it. And so most patients will require adjuvant treatment with chemotherapy, and first-line chemotherapy, usually with our carboplatin and paclitaxel. So this was the same case of the 84-year-old patient. We're able to remove all her disease. And fortunately for her, fortunately and unfortunately, fortunately, this returned as a serous borderline tumors of the ovary. And this was a stage 3A disease. There were non-invasive as well as invasive implants. And so this patient went on to do chemotherapy for treatment. This is another patient as well, extremely large abdomen, large pelvic mass, large volume ascites. She also underwent debulking surgery. And at the time of surgery, we were able to remove this large left ovarian tumor. Also on the right side, you can see that as well. And then she also went on to have adjuvant chemotherapy. So in some cases, though, when a woman presents with a large ovarian mass, and this is likely ovarian malignancy, and based on our imaging modality, if the imaging modality is suggesting that this is significant burden of disease, if the CA125 is significantly elevated, there are some patients that we may not be able to achieve optimal debulking, optimal cytoreductive surgery at the time of surgery. And therefore, neoadjuvant chemotherapy, meaning giving chemotherapy before surgery, is something that we have embarked on. And many studies have shown how significant this can be in assisting in going after the tumor at the end of chemotherapy. This one randomized trial that compared primary upfront surgery versus giving neoadjuvant chemotherapy followed by surgery. And the conclusion from this study showed that neoadjuvant chemotherapy and primary debulking surgery have the same efficacy when used at their maximal capacity. So yes, if we do have a patient and the burden of disease is significant to the point where we cannot debulk these patients to almost zero, then chemotherapy can be given, which may shrink the tumor and therefore allow for a better surgical debulking procedure. But the problem is that despite surgery for ovarian cancer in our postmenopausal woman, surgery and chemotherapy, most patients will have recurrence. So their disease will come back. And so if the disease return in greater than 6 months after being challenged with our platinum-based treatment, then these patients can actually be re-challenged with carboplatin and paclitaxel. If the recurrence occur in less than 6 months, however, then we say that these patients are platinum resistant, and therefore we have to switch gear. We have to switch to a second-line chemotherapy. But with time, there's been a paradigm shift in how we manage ovarian cancer. In 2011, bevacizumab was introduced as part of the armamentarium in treating our patient because of that recurrent risk, just giving carboplatin and paclitaxel alone. Could we improve on reducing the recurrence rate? Could we improve on increasing or improving overall survival? So bevacizumab came into play, and bevacizumab, another name is Avastin, is a vascular endothelial growth factor. And one of the hallmarks of cancer is increased blood supply, a term called neovascularization. And therefore, using bevacizumab, we can reduce that blood supply and therefore reduce the tumor growth. So that was the intent of this drug. Then in 2018, we came across our poly ADP ribose polymerase inhibitor known as PARP inhibitor, and this then entered into the standard treatment for epithelial ovarian cancer. And particularly for patients who may have germline mutation in the BRCA1 and BRCA2, PARP inhibitors has been shown to reduce progression-free survival and to some extent their overall survival. And therefore, all patients who have an epithelial ovarian cancer should have genetic testing performed. Another modality of treatment is HIPEC. So at the time of doing the surgery to remove all the burden of disease, and if we have achieved significant debulking, then given the chemotherapy, heated intraperitoneal chemotherapy at the time of surgery is one modality of management of this patient epithelial cancer. Currently, we don't offer that in Jamaica, but something that is being looked at. Other management involve the use of immunotherapy because some tumors grow along a particular pathway. And if we can identify these, we'll call these checkpoints, then we can use checkpoint inhibitors to help to reduce the the progression-free survival and overall survival in these patients. This, of course, is a young patient. She was 14 years old, and she presented with large pelvic mass that was growing over the last 3 months, and very uncomfortable and pelvic pain. And so an ultrasound scan was done on this schoolgirl, and this demonstrated a large, complex pelvic mass, as we can see here. She then went on to do a CT scan, which showed a complex pelvic mass with bilateral urethric compression, but there was no evidence of disease on imaging beyond the ovaries. We went on to do tumor markers on this patient, and one of the tumor markers that was done is called the alpha-fetoprotein, and this was significantly elevated. So for a younger patient, the management's a little different, yes? In that if the disease is confined to one ovary, then we can just remove that side only. So in this patient, as you can see in this picture, we were able to just remove this left ovary and tube. Notice the right ovary, even though there's something here, I think this may be a corpus luteum cyst, but the ovary itself on this side was normal. So we're able to do a unilateral salpingo-oophorectomy and staging. So we're able to take some momentum, able to sample some of the pelvic peritoneum, and that was sent to our pathologist. This is the specimen that was removed. It was greater than 20 centimeters in its widest diameter. She underwent left salpingo-oophorectomy or mentectomy, pelvic peritoneal biopsies. We also send the fluid off for cytology. That fluid actually returns showing the presence of malignant cells. And the histology, the final pathology on this was an immature teratoma. Remember, we said that the most common germ cell malignancy in this age group is dysgerminoma, and this was followed by immature teratoma. So in this, they were seeing a lot of immature elements such as bones and cartilage and teeth and hair, and a number of immature tissues that were actually seen in this specimen as well. So this patient actually went on to receive chemotherapy, but in this case, she got BEP, bleomycin, etoposide, and a platinum-based chemotherapy known as cisplatin. She has completed 3 cycles and is doing quite well. So how do we follow up our patients with particularly the epithelial tumors? So once we have done our surgeries and once these patients have undergone their adjuvant additional treatment with chemotherapy, then we do serial physical examination, usually every 3 to 4 months initially, probably for the first 2 years, followed by 6 monthly for the next 2 years, and then yearly thereafter. So we examine, we do a history, how they're feeling. We also assess in terms of their tumor markers, and we monitor their tumor markers, because if the initial presentation, this tumor marker was elevated, then certainly post-surgery and post-chemotherapy, we're expecting that this tumor marker should reduce in terms of its value. We also know that if the tumor marker is rising, then our index for recurrence now increases, and so we do further imaging. And if that's the case, then this patient may require further chemotherapy. But despite advances in surgical management of ovarian cancers, as well as the chemotherapeutic management of ovarian cancers, the 5-year survival is quite dismal. Less than 50% of patients will survive in 5 years. So if we look over the years at this graph, look at this, a stage 1 disease, and luckily if we can catch our patient with a disease that is confined to the ovary, then that'll be great, but no significant change over the years in terms of 5-year survival. Stage 3 is the most common presentation, right, when patients present to us. And notice again, no significant rise in terms of overall survival over the years for these patients. So what can we do? And is there a screening modality? And unfortunately, there isn't. The absence of both an effective screening method and early detection contributes to the late presentation and poor prognosis in these patients. But may I say, and we may pause to look at this, because a number of our patients do present with vague signs such as bloating, dyspeptic symptoms, etc., which mimics other types of diagnoses. But if we can start the evaluation in these patients early, then maybe we would be able to detect some of these cancers a little earlier, and then having an earlier intervention, maybe we can improve on the overall survival. So a number of screening modalities, a number of societies have looked at how can we screen, and none of these have shown to improve overall survival using transvaginal ultrasound of CA125, the UK collaborative trial, they're using the human epidermis for CA125, and none of these have been shown to improve overall survival in these women. But what about our patient that may carry a mutation in these genetic, for example, BRCA1 and BRCA2? Yes, maybe. Maybe we can screen these high-risk patients, or maybe we can do something to reduce the risk of developing ovarian cancers in these patients. Note that those patients with genetic predisposition, they tend to present a little earlier than those women who have sporadic disease, who develop without genetic predisposition. And so if the BRCA is positive in our younger patients, can we do something to reduce that risk? Yes. We may be able to remove the ovaries and tubes after they have completed their reproductive career. Yes. And by doing so, we can reduce the incidence or the risk of developing ovarian cancer. If we remember, one of our greatest actresses in the world, Angelina Jolie, was known to have BRCA, was BRCA positive in her family. She went on and had a double mastectomy performed to reduce her risk of developing breast cancer. And so over years, we have understood a little bit more about the biology of ovarian cancers, about how it develops. And what we have recognized is that a number of our high-grade ovarian cancers actually develop in the fibril end of the fallopian tube. And when these tubes are dissected, what they're seeing are precancerous changes in these tubes known as STIC, serous tubal intraepithelial carcinomas. Yes? And so if that is the case, right, can we then remove these fallopian tubes at the time of doing benign surgeries, and by doing so, reduce the risk of developing ovarian cancers? And so one of the pioneers in discussing this about risk reduction in terms of removing the fallopian tubes at primary surgery for benign causes such as hysterectomy for fibroids, etc., was a Canadian gynecological group. And what they found is that surgical removal of the fallopian tube at the time of hysterectomy, even when the ovaries are conserved, could reduce the risk of developing ovarian cancer. What they've also advocated is that if we replace tubal ligation with excision, meaning removing the tubes at the time, particularly say doing a cesarean section, instead of just doing a resection of just a part of the tube, they're advocating removing the entire fallopian tube. And that way, we can reduce the incidence of ovarian cancer. And so this was put out in a journal, and they've demonstrated their work and how this has improved significantly the number of ovarian cancers that we're seeing since they changed their treatment modality for those patients. So notice here that in 2008, right, when you look at patients in the British Columbia group, they were doing hysterectomy alone here, hysterectomy in the red with bilateral salpingectomy, and in the blue, hysterectomy with bilateral salpingo-oophorectomy. And so over the years, there's been a change in the management. They're now including more bilateral salpingectomy in their in their surgical management of patients with benign disease, and in some cases, improving slightly, a little bit here in terms of doing bilateral salpingo-oophorectomy. Right, and so their studies have shown significant changes, and this is a journal article showing the effect of tubal sterilization technique on the risk of serous epithelial ovarian cancer and primary peritoneal cancer. And this has shown a significant reduction. Any tubal sterilization reduced risk of serous epithelial tumor and primary peritoneal tumors was significant when these were used in the surgical management. So just to conclude that all women, especially postmenopausal women with possible early signs, those vague symptoms, and who may have a pelvic mass should be evaluated early. Young women with a pelvic mass, and those are germ cell tumors, because these have a propensity to spread fast, they should have urgent attention. All women with ovarian tumor or postmenopausal particularly should have genetic testing. So because by doing genetic testing, we may be able to add additional drug to the armamentarium of what we already possess. So we now understand a little bit better in terms of the paradigm shift that has occurred in terms of the management of ovarian cancer. And therefore, since there is no screening for ovarian cancer, then our focus therefore should be how can we reduce this? And so by doing opportunistic salpingectomy in low-risk women, then we can reduce the incidence and mortality from epithelial ovarian cancer. So I'll close by saying that all truths are easy to understand once they are discovered. The point is to discover them. I thank you very much for listening.
All right. Thank you very much, Dr. Bambury, for your presentation. Up next, we're going to hear from Dr. Davidson, who would be speaking on cervical cancer in the Caribbean and the Jamaican response to the World Health Organization global objectives. Dr. Davidson is currently serving as the Director of Non-Communicable Diseases and Injuries Prevention in Jamaica. And she has over 27 years of experience, worked at various levels of the healthcare system. She has held positions in the Caribbean Public Health Agency, including Assistant Director of Disease Surveillance, Prevention and Control, and the head of the Chronic Disease and Injury Department. Her career in the public health encompasses diverse areas such as health promotion, health system strengthening, epidemiology, clinical guideline, and policy development implementation at the national and Caribbean level. Dr. Davidson.
Hi, good afternoon, everyone. Happy Sunday. I'm happy that everyone could have made it today on a blessed Sunday. I would like to thank the Cancer Society for inviting the Ministry of Health and Wellness to do this presentation, a very important presentation to this group. So I'll be talking about looking at cervical cancer in the Caribbean and essentially where Jamaica is at with respect to the targets, global targets for cervical cancer. Now, can you imagine a world where Jamaica, the world where cervical cancer is eliminated as a public health problem? So we wouldn't be talking about cervical cancer. No, we'll be moving on to other cancers and looking at addressing other cancers by putting these interventions in place. However, every 2 minutes, a woman dies from cervical cancer. Although the knowledge, the tools to prevent and eliminate this disease is available or already exists and known, and you would have heard a lot about that this morning. HPV vaccination, we know, can prevent a vast majority of cases, along with screening and treatment. And this is what we call a path to elimination with a combination of the three areas. So what the global community has done is we've galvanized around this vision of a world where cervical cancer is eliminated as a public health problem. And so WHO launched this global strategy and plan of action that over 196, about 196 countries, somewhere around that, have actually committed to this. And this is through three key elements: vaccination, screening, and treatment. But does elimination mean that we'll never have any cases of cervical cancer? So what does this term mean? And the term elimination as a public health problem is defined as achieving this measurable goal target set by WHO for a specific disease based on the population data. So for cervical cancer, it's expected that countries to be deemed as having eliminated cervical cancer, then the age-adjusted cervical cancer incidence rate should be below 4 per 100,000 women years for being considered as eliminated as a public health problem. So how do we get there? And these key strategies have been outlined globally and based on the existing evidence that we have is that we want to have 90% of girls fully vaccinated with HPV vaccine by 15 years of age, 70% of women screened using a high-performance test, and that means cytology-based or HPV. And now we're moving to say concrete, which really should be HPV testing, but both are considered. So we get the 90, 70, 90. Yes, in looking at this vision for a world without cervical cancer, where it's eliminated as a public health problem, we're looking at getting countries to an incidence rate of 4 per 100,000 women years and meeting the 90-70 targets. We should be on the road to meeting these targets by 2030, which is just 5 to 6 years from now. And so this is where countries need to be in terms of on the pathway to elimination. So WHO looked at mathematical modeling and really looked at using this key strategy, what would be the outcome? And they looked at from 2020 to 2021, 2020, which is really a 100-year period. And as you can see in red, it's a status quo. If we do business as usual, you will see on the chart that the incidence rates and mortality rates remain high. But with implementing this strategy, you see a steep decline, both in incidence and mortality over this 100-year period. And this estimate was done for low and middle-income countries, about 78 of them, looking at what would be the projection and the timeline for getting to this elimination target. So this target would mean that we would see a mean cervical cancer incidence rate reduced by 42% by 2045, 97% by 2120, and we'd avert 74 million new cases of cervical cancer. By 2030, we hope that we will avert at least 300,000 deaths. And you can see it's in the millions with respect to those averted in 2070 and 2120. So this estimate mathematical modeling was done over a 100-year period. So when we look at the burden of cervical cancer by region from a global perspective, we see that the Caribbean is somewhere the mid road. So the Eastern, Southern African, so the African countries, Micronesia, South America, Central America within our own region here are above the Caribbean when it comes to cervical cancer incidence and mortality. However, we still remain very high and above most of the North America and Western Europe and Northern Europe as well. So when we look at the global incidence, we see where most of the incidence of cervical cancer, if we're looking at the proportion, is in Asia, followed by Africa, and then the Latin America and the Caribbean in terms of regions, and then Europe, followed by Europe, with Northern America being the least, and Oceania. Now, when we look at cancer incidence and mortality in the Caribbean, now coming closer to home, we see that cervical cancer is ranked. If we look at the incidence rate, it is still not in the top 5. And then we look at mortality, we see that, breast, prostate, and colorectal cancer are much higher than cancer of the cervix. And a lot of that we do attribute to the fact that in the Caribbean, we do have programs in place that have been addressing cervical cancer. Now, when we look again here, this just gives you a proportion of the burden as it looks at overall burden of cancer with respect to cervical cancer. It's not ranked in the top 5. However, for women, of course, we know it is a female disease. It is ranked 4th. So from a public health perspective, when we look at overall cancers that we prioritize, we're looking at generally at both sex. It's not in the top 5, but it is ranking 4th. And this is an improvement in the past where cervical cancer was actually number 2 in the Caribbean when it ranked in terms of female cancers. Now, when we look at the 8 standardized rates for incidence and mortality by country, we see that Jamaica is ranked 3rd here in terms of cancer incidence and certainly cancer mortality. And this is the countries that data is available for and that are part of the cancer registry. Hope there wasn't any further data for other countries. Now, when we're looking at the WHO targets, where we know in Jamaica, and we'll look at Jamaica with respect to the data available also as it relates to the Caribbean. Now, when we talk about this 90-70-90 rule, this ties into the approach that we've been taking globally and in the Caribbean region, and certainly in Jamaica, a life course approach to cancer interventions. And that just means what we call from the womb to the tomb, where we start from 9 years old on to until beyond 60 years to do key interventions and approaches that address cervical cancer. And this is, we know that cervical cancer is a slow growing or takes a number of years to develop before from the precancerous lesion to cancer itself. And that gives us a window of opportunity not only to eliminate and to really reduce the burden, incidence, and mortality due to this condition. So here, we have the vaccination in pink. We do vaccination, HPV vaccination, which we'll talk about more, for both boys and girls currently now in Jamaica. And we do health promotion, education. We deal with sexual reproductive health, addressing safe sex measures. And then we go on to the secondary prevention, which is screening. And screening is recommending that it doesn't start before the age of 21. And so that is the time. So whilst we know that HPV infection is common, HPV infection will itself go away by itself without any intervention. However, we know that ages 30 and beyond, it tends to persist when we find HPV at that point in time. Then it's a higher risk for it to progress towards developing into cancer, pre-cancer, and cancerous lesion along the continuum. And so you have secondary and tertiary prevention along this age profile. So where is cervical cancer mortality rates? And I'm happy to state that with respect to mortality in Jamaica, we have seen a downward trending of mortality rates per 100,000 population for cervical cancer. We did not have the premature mortality component of it, but and we see where we think that despite or where we may have challenges and gaps in the program, that through the efforts of our program and certainly Cancer Society and you that are part of this process, we have been able to see a downward trend over the past 10 years, decade, in cervical cancer mortality rates. And if we looked overall in terms of overall death rates for both male and female, it's no longer in that top 10. Of course, when we look at female, it is the second most common, third most common cancer for women. So we know we're doing improving in terms of our decline in mortality rates. So where are we with respect to the first target? And that target is to have 90% of girls fully vaccinated with HPV vaccination by 15 years of age. Now, when we look at the Caribbean, the Caribbean countries, at least the CARICOM, all of them have introduced the HPV vaccination. And Bermuda, within the context of the Caribbean, was the first to introduce it as a part of their routine schedule, and Jamaica introduced it in 2017. The last of the block was Martinique, which is actually an associate member of CARICOM. Now, in Jamaica, our primary administration of the vaccine, we use the Gardasil quadrivalent vaccine, and we give one dose, so it's one dose, and for both girls and boys. So for those who weren't aware, we actually introduced the vaccine for boys last year. And depending on, for those who are 15 and 26, it's 2 doses, 6 months apart. And for those who are immunocompromised, it's 3 doses. This goes along with the whole public education on cervical cancer. So our pitch is around cervical cancer, and we also do education around STIs and tobacco use. So where is Jamaica? Well, Jamaica is really not doing well at all. Our vaccination coverage is at 4%, and the highest in the region is, in fact, Dominica at 83% for the vaccination coverage. And this is preliminary data that was reported by PAHO WHO. And we know that the majority of Caribbean countries, and so you will see Jamaica here, the lowest for the region. The majority of the Caribbean countries are in fact less than 30%. And there are many reasons and challenges with the vaccination. And as you can, we experienced through the COVID scenario, there are lots of socio-cultural challenges, a lack of buy-in of not only the public, but also our own healthcare professionals in terms of promoting the vaccine. The vaccine is not mandatory, and the vaccine is administered within our facilities. So there's a concerted effort to now roll out and rebrand and the vaccination communication campaign, and to reach both parents, community, and to raise awareness not only for women, but also for men about the importance of this vaccine. So many of you may already have seen a lot of these on social media and or television. Also, there's a lot of misinformation, and of course, there's the anti-vax vaxxers. So we didn't meet that target, and we're not meeting that target. So with respect to the second target, 70% of women screened using a high-performance test by 35 years of age, and again by 45 years of age. And this is at least twice in their lifetime, or a maximum of 10 years apart. Well, we know that in 1999, we established our National Cervical Cancer Screening Program, and it's primarily cytology. It's cytology-based pap smears. We do have a few sites in the southern region that are doing visual inspection on acetic acid, but those are a few in a few cases. With respect to routine screening that is done in our public sector, we have screening that's facility-based, community-based screening as well. And of course, in the private sector, it's facility-based screening. We work closely with entities like the Jamaica Cancer Society around promoting screening, conducting screening, and public education. We also have our diagnostic services, services in hospital primarily, and our pathology services. And we really want to move these services into primary care with our efforts to reform primary care and to increase greater access. So also in 2020, we published our evidence-based screening guidelines, which includes cervical cancer. Prior to this, we had a standalone guideline, and we have incorporated cervical cancer in this multi-disease guideline. And it includes recommendations for both cytology, algorithm for cytology, and HPV as the main modality of testing, as well as VIA. So where are we with screening? And here we see the results, recent results released last year from the Reproductive Health Survey. And this survey started in 1997 and was a primary survey that we used to monitor how well we're doing with screening. And for those women 15 to 19 years old who ever report ever having a pap smear, we see that percent continues to increase. So it's at 67.2% coming from a 50% in 1997. And just to highlight that routinely in the public sector, once you're doing a pap smear, then we also do breast examination as well. So for the health and lifestyle survey, they report 15 to 64, 5% having done HPV tests. So they looked at other modalities of screening. About 70% report ever having done a pap smear, with 35 to the 44 age group showing the highest prevalence. So 35 to 45 is significant. As mentioned, that falls within the age group of the target age for screening based on the global campaign. With respect to pap smears done, persons with was high in women with primary or lower education compared to secondary and post-secondary. It may suggest that these women are accessing services in the public sector more, and this is why they have a higher level of screening. Less than half of the women, though, in a reproductive age group had reported having done a pap test in the last 3 years. But this survey was done in 2016, 17. So a more up-to-date survey in 2021, the Reproductive Health Survey, shows that for the age group 35 to 49, which falls within the global target, we have over 90% of persons reporting ever had done a pap smear. And we know a lifetime of at least doing a pap once in your lifetime can significantly reduce your risk. Up to the 30 to 34, that it was 86.2%. So, and the 25 to 70 to 25 to 29. So all of these age groups actually fall within the target. And so put this in green to say we are actually meeting this target. No, some of the reasons for never having done a cervical cancer screening test included that they never thought of it, that they did not, the doctor was not recommended by the doctor. That was high as 11.6%. And no, they thought because they didn't have any problems that they didn't need to do it. And so not thinking about it means, you know, the need for us to do more education, to continue to do this education, to raise awareness about when you need to do a pap test. I must say the limitation of this is that really where our recommendation is that it's done from age 21 up. And also doctors need to, and healthcare providers need to ensure that they're recommending these tests to be done on their routine visit or any visit to their particular facility for any other problems, whatever the health problem is. So when we look at further on some of the practices, females who were in union were more likely to have done a pap smear. Prevalence was lower in females in common law and visiting relationships, albeit pretty high. And then among females who had ever been screened for cervical cancer, which were 7 out of 10, did so within the recommended 3-year period, again falling within the WHO target. So for screening, we're in fact meeting the target according to WHO. With respect to 90% of women identified with cervical cancer being treated, here is where the data was not available. And this is where we need to capture more data to monitor what is happening here. We do offer a wide gamut of services within our hospitals, but this is where our strengthening of our health information system will come into play. So surveillance and monitoring for the Elimination Initiative is very key. And here I'm sharing with you from WHO, the cancer continuum and all the different elements in order to track the Elimination Initiative, which, as you can see, the projection is for the next 100 years. And here you see where you need to have your population-based surveillance systems in place, including tracking HPV prevalence through surveys, cervical cancer incidence, cancer survival and mortality, and also your vaccination and screening coverage and your treatment care, as well as end of life. And this is done through a series of both population-based and surveys, registries, and your health information system. So with respect to Jamaica, we do routine mortality surveillance that's led by our national epidemiology branch, and also statin tracks our deaths and births, the Statistical Institute of Jamaica. We also have a national cancer registry in place to track cancer incidence and prevalence, and that is being strengthening, and we're working very closely with the Caribbean Cancer Registry Hub. And so we hope to have data available over time, and to ensure that that data is very, very important in order to assess whether we've met our outcomes in terms of our incidence and prevalence. And the incidence and prevalence data reported earlier for those countries are really estimates that are prepared by WHO. We also have our cancer registries in our facilities. We have patient administrative databases, and we do have the quality assurance audits of our screening services and cancer management. We have our 3 key surveys that gather data to track how we're doing in terms of cervical cancer screening and coverage, and also knowledge and attitudes and practices related to cervical cancer screening. And we expect in 2025 to have our next Jamaica Health and Lifestyle Survey in place, and collect more data, perhaps to look on treatment to get some of that information to support understanding of where we're at as well. We're also strengthening our health information system through the IDB project, which is supporting putting in an electronic health record system within our hospital and primary care, which will help us to also track some of this information much better. So where we know, and this is a high-level summary showing we're not on track for vaccination. We are on track. We have a green in terms of having achieved that target based on what WHO has aligned, put out as a target. And we do need data to support reporting on assessing where we're at with respect to treatment. So in getting to 90, 70, 90 over the horizon, we have the finalization of our elimination plan and mobilization of resources to get on track by 2030. The 2 areas, as you noted, the gaps we identified. We've ramped up promotion of the HPV vaccination with a rollout of a national public education campaign. Last week, Vaccination Week in the Americas was launched in Jamaica with a focus on rolling out our campaign to really catch up. We continue to promote screening and to track and monitor what's happening with respect to our screening program. And we will be introducing HPV screening via pilot in the public sector in the coming fiscal year. We continue to work around improving infrastructure for diagnosis and treatment as part of our primary care reform, and are also our scaling up and building out of our infrastructure for our hospital through this integrated delivery system, where we want persons to move smoothly through continuum of care, through a cascade of care, right from primary care to hospital, tertiary level, and back. And we have the expert guidance of our National Cancer Technical Working Group, chaired by Dr. Dwight Lowe, and the NTD committee. So some take-home points I want to leave with you is that we can be positive about the projection of cervical cancer in terms of the improvements that have been made, but the burden is still high. The deaths are declining in Jamaica, but vaccination coverage is extremely low and not at target. So Jamaica has met the global screening target for cervical cancer, but to get to elimination, we need the 90, 70, 90 rule. And so we had the first ever global cervical cancer elimination forum in March of this year. And Dr. Tedros, the Director General, leaves us with this remark: we have the knowledge and tools to make cervical cancer history, but vaccination, screening, and treatment programs are still not reaching the scale required. And where we really have to push and scale up, and we need you to join us in that process around getting our girls, our boys vaccinated, and ensuring that every child gets vaccinated up to the age of 15. We also are working on improving our treatment programs and also continuing with screening. So the time is now. Let us all work together towards elimination of cervical cancer. Let us be on the right side of history. We owe it to our mothers, grandmothers, sisters, daughters, husbands, sons, our families, communities, and the next generation. These are the references for our presentation today. And for more information, please visit our website. Thank you. Any questions?
So it's very encouraging to know that there are plans in place to advance the element of screening in order to curb the incidence of cervical cancer. And of course, getting on board with the HPV testing as possibly another form of not just co-testing, but primary screening as well. So our next presenter, as you may imagine, is a radiation oncologist, acting head of the Department of Radiation Oncology at the Kingston Public Hospital. A very engaging speaker, and interesting, I'm sure today would be no different, is Dr. Kern Pemberton. He is going to be speaking on an update on radiation treatment in cervical cancer.
Good afternoon. Thank you so much for having me. I really do appreciate it. And thank you for all the presenters before for your succinct presentations. I hope to be quite brief. Let's see if I can do that. Yes, that's good. And for those of you who know me, I am Dr. Pemberton. I'm in fact a radiation oncologist at the St. Joseph's Hospital National Cancer Treatment Center. In addition to the Radiation Oncology Center of Jamaica, I function as the acting clinical director of St. Joseph's Hospital's National Cancer Treatment Center for now. And as of today, I'll be talking about radiotherapy in cervical cancers, and of course, we'll give you an update. This is my contact information in QR form. Let's proceed. So the objectives for today lie in the fact that we're going to talk about how radiotherapy works. Notoriously, I always give question and answer sessions, so we're going to do some case scenarios. We're going to look at where we're at in Jamaica and beyond the new highway to St. Thomas, what's new in Jamaica in regard to radiotherapy. So this is just a test. I think we have a polling station. So we're going to just start off with something a bit general, just on general knowledge. The first question I'm going to ask is nothing to do with radiotherapy, but just to see how the polling station goes. And also something interesting as an icebreaker. Okay, in which country was Rita Marley born? You can place your answers in the polling station, and then I will give the answer at the end. So this is quite an interesting question and answer. So let's see. Are we going to get the percentages, or should I just proceed to the answer?
Proceed, please.
Okay. So, for those of you who said Cuba, you're absolutely correct. It's an interesting fact. She was born in Cuba and then immigrated to Jamaica afterwards. Alrighty, so now we're going to get into the radiotherapy aspect of things. How does radiotherapy work? Does it cause cell membrane damage? Does it cause DNA damage? Does it just cause the cell to burn? Or the fourth option, does it laser the cell? You can tell me your answers, place your answers, or think about your answers and decide. Righty. So if you said it causes DNA damage, you're absolutely correct. The answer is B. Now, the radiotherapy is a peculiar sort of treatment. What happens is in cancers, you have some sort of signal change that causes mitosis to happen at a faster rate. And ideally, to maintain some sort of equilibrium as you create two new cells, the parent cell dies off. However, in cancer, that process is not quite regulated. And in that case, you can develop more cells in the actual area or in the organ, and that develops into a tumor. What you can do when you ever have that sort of problem is, yes, you can do an operation. Yes, you can do chemotherapy, but the sort of physiology of radiotherapy lies in the fact that it's an X-ray treatment that's able to go to those red and the blue areas that you can see on my screen. Those are the DNA strands, and they can cause the DNA to become damaged. When that happens, the cell is sort of brain dead, so the cell is still alive, but when it tries to make two new cells, because the red and the blue is fragmented, it can't make sense of it, and therefore you can't undergo the process of mitosis and make two new cells, and therefore the cancer dies off. So the radiotherapy is a sort of external treatment that does not cause many side effects in terms of during the actual procedure. It comes from a machine that looks like this, and this is called a linear accelerator, and it has made news many times. We have a number in the country, the St. Joseph's Hospital, the Radiation Oncology Center of Jamaica there too, and the Cornwall Regional Hospital as well. Now, before we got to this type of technology, things were sort of happening in Jamaica, but the older technology. So I'm sure those of you who have been with the Jamaica Cancer Society for years would have heard about the cobalt machine. Now, this machine was in fact the pioneer or one of the mainstays of treatments in the country. And then before that, we in fact had something called a KV machine, and this is sort of in a museum now. And the difference or the differences are based on their penetration. So the one on the right, which is the LINAC, as you can see here, there's not much yellow on the surface. And the area or the tumor that we want to treat here is in green, and the yellow rays are sort of conformal and circular around the green area. And that's the newest technology. The older technology, the cobalt, in order to get the orange around the green area or the tumor area, it formed a box. And as a consequence of that, the orange area will treat areas outside of the confines of the tumor. And in addition to that, just to get that orange coverage, it will deposit a lot of orange on the surface. So that's why there was some sort of negative connotation back in the day when it comes to the cobalt, calling it the burning. However, what happened was in order to get the radiotherapy within the actual tissues, the radiation had to be deposited somewhat on the skin. And in the older technology, you would have seen that the red is more so on the surface than in the orange. So therefore, the older technology caused even further skin reactions. But I'll have you know that cervical cancers were one of the first set of cancers that were treated on this machine in Jamaica. So what has been happening is we've been having improvements in our technology and our normal tissue and normal organ sparing. So in terms of the new technology, which is the one to the farthest right, yes, we can conform to the area, and yes, we could reduce the amount of radiation that goes to the skin or to organs that don't need radiation. However, within it itself, there are two types. There's something called the 3D conformal radiotherapy and the intensity modulated radiotherapy. And the difference is quite glaring, or the differences are glaring. So in the 3D conformal radiotherapy, it's as if the technician or the physicist or the dosimetrist is driving the machine, and they're trying to figure out how to get to the tumor from the outside. What happens as a result of that is there's room for human error, there's room for it's not room, but it's more so it's a quick non-conformal sort of, but not as precise as a computer generated technology on the right, which is what we call intensity modulated radiotherapy. However, as a result of that, the labor intensiveness of the IMRT is quite glaring, and it becomes a more expensive procedure. But the good thing about the IMRT is that you can get a sort of conformal treatment where you're treating the tumor and really trying to avoid the normal tissues to some extent. However, given that, you still do encounter side effects which we cannot control. And radiotherapy becomes that art or delicate balance between trying to reduce the side effects and to treat the tumor. So an example of the 3D conformal radiotherapy where basically the technician is driving the machine, and on the right, just like these German cars, the technology where the machine drives itself, you can see here that if I'm trying to treat that area, it forms a box. But on the right, it actually conforms to the area, and therefore, as you some radiologists or persons who are familiar with anatomy would know, the bladder on this picture on the right is not getting that much radiation in comparison to the one on the left. For those who don't know, the bladder is this dome-shaped structure right here. So this is what the newest technology we have is in Jamaica. This is called the True Beam. It's available in the private sector. And this technology has the ability to see on the inside every day. So in regard to when we do radiation, we identify the area on the CT scan before the patient starts the treatment. And then when we place them on the machine, we actually deliver the treatment based on coordinates. But this machine is so sophisticated that it is able to see on the inside, make sure that the bladder is full, make sure that the rectum is empty, and identify the area that you would love to treat. I see the answers coming in here. So most people thought that Rita Marley was born in Cuba. That's correct. It was half-half for Cuba and Jamaica. And we got some persons saying that it causes DNA damage. But yes, so the peculiarity of radiation is that it causes DNA damage. All righty, so let's go into the case scenarios. We have a 30-year-old female who presented with intermenstrual bleeding and also postcoital bleeding. She was found to have a large mass placed in the cervix with extension to the lower third of the vagina. On imaging, she has no lymph nodes or pelvic sidewall involvement. Which stage cancer does she have? So the answers are either A, stage 1, B, stage 4A, or C, stage 3A. So the answers are coming in. We have a number of persons staying stage 1. We have 33% staying stage 3. And the answer is stage 3A. Now, this is a diagram that I sort of use in my head. So this is looking at the patient from the front or anteriorly. So I always tell my colleagues or my junior doctors, when you're thinking about it, stage 1, sorry, confined to the cervix. Stage 2 is starting to grow outside. And I always tell them that A is down and B is to the side. So 2A will be when you have the upper two-thirds of the vagina involved, whereas 2B will be when you have your parametrium involved. Now, the Spiegel classification is quite strategic in that it sort of tells you, what you're dealing with in terms of prognosis, but also it tends to dictate how you treat patients in radiation. Now, if it's stage 3A, now you're going into the lower third of the vagina. Embryologically, what happens is the upper two-thirds of the vagina meets the lower third of the vagina. As a result of that, the lymphatic drainage is sort of different. And we'll get to that in a little bit. But I want you to see that stage 3B now, you're going to the side again, but beyond the parametrium, so you're going to the pelvic side wall. And then stage 3B also indicates that you can get some sort of degree of hydronephrosis. And then stage 3C, as we know, lymph nodes follow vessels. So this would be your aorta, your common iliac, your external iliac, and your internal iliac. So what happens in that case is the para-aortic is a little bit more riskier, sorry. So therefore, what happens is stage 3C2 becomes when you have para-aortic involvement. However, stage 3C1 would be your below the aorta, talking about your common iliacs and your external and internal iliacs, sorry. So these are the sort of local control rates you get based on stage, and this sort of dictates what you do for each stage. And of course, size matters when it comes to the size of a cervical cancer. More than 4 centimeters, not so favorable in terms of doing surgical therapy. In terms of lymph node involvement, so it is sort of congruent that if you have a lower stage, your chances or percentage chances of having lymph node involvement, they are lower. However, as you go up to stage 3, you can also start thinking about the chances of para-aortic involvement, as we saw just now. Now, the problem with the stage 3A, where you have the lower third of the vagina involved, is that you can get drainage to the internal or the inguinal nodes. And what happens as a result of that is this image on the right speaks to what I would have done using the 2D, meaning X-ray planning. I cut it between this space here because that's where the aortic nodes or the common iliac nodes are. And then I'll try to get the obturator nodes and the pelvic side wall nodes on this side. And then the tumor, if it's high up, you can just drop it right there at the base of this is what we call the obturator foramen. But if you're dealing with inguinal node involvement, ideally you're supposed to identify it. But if you have to actually treat that area successfully, you're looking at widening your field of radiation. So the sort of danger in it lies in the fact that if I know that there's lower third of the vagina involvement, and I go ahead and treat using conventional treatment for lower stages, I would have totally missed the inguinal nodes. So that's why it's important to have the staging quite accurate. And what we do at the Kingston Public Hospital is we have a multidisciplinary team meeting where we in fact meet with the gynae oncologist and we examine the patients concurrently and we designate the stage and we're absolutely sure that this is what we're going to use as the final stage going forth. So it acts as a form of quality assurance. Now we're going to go back to the other case or another case or same case, sorry. She was found to have a high BMI, an HbF 7.0, and a platelet count of 130. Which of the following is an important prognostic factor in this case? Is it the BMI? Is it the hemoglobin? Or is it the platelet count? Let's see your answers. So some people are split between BMI and hemoglobin. And if you said hemoglobin, you're absolutely correct. So this is one study looking at the glaring difference in survival in a cervical cancer patient who is treated with an HB above 12 or less than 12. In the clinical setting, we just try to maintain it above 9. But that is prognostic, and there's also some theory to it. In radiation, to get the DNA damage from the rays, sometimes what happens is we damage the water in the cytoplasm around the DNA, and then this goes on to actually attach to the DNA and break it. So what we do is we're breaking up stable homes. And in order to stabilize the breakup, to call it final, who does that? Oxygen. So therefore, in addition to the hemoglobin levels being high and sort of a surrogate for the oxygen carrying capacity, what we do know radiotherapy-wise and theoretically speaking is that when the oxygen levels are high, that DNA damage that we want to get in the cancer cells is stabilized by oxygen. All right, so we do encourage persons when they're referring patients to us for radiation to ensure that their hemoglobin levels are at optimum levels so that we are also trying to attack the prognosis aspect of things and to ensure that our radiotherapy is effective. Now, she has a good performance status and she looks well enough for treatment. The decision was made to treat this patient with external beam radiotherapy as an initial phase, and I say that sort of lightly. Which dose would you recommend? Would it be a single gray of 45, single shot of 45 gray? Would it be 25 days of fractions, we call it in our jargon, with concurrent chemotherapy, meaning chemotherapy is given with the radiation? Or would it just be 20 gray in 5 fractions? Oh, this one was a firm answer here for B. Well done, guys. So we are giving 45 gray in 25 fractions. Now, the reason why we break up the radiation into days is quite interesting. So we have something called the 4 hours of radiotherapy. When we break up the radiation into days, 25 days, and we allow for time in between the treatments, what happens is the cancer is being treated, and preferentially as well, the normal cells, so we're talking about the bladder, the rectum, the skin, they get time to repair. So that's one of the reasons why. When we actually break up the radiation into days, however, especially in cervical cancers, you want to get your treatment completed by 7 weeks. Why? Is because if you break it up into days and you allow the total treatment time, meaning the 5 weeks in the initial phase, to extend beyond a certain period of time, what can happen is the cancer cells can actually become a little bit resistant to the treatment, and you can get repopulation of the cancer cells. So therefore, we have to be cognizant that even if we break up the radiation into days to allow for repair of the normal tissues, you can get a certain extent of regrowth after a certain time. So this is why we tell patients, even though it's broken up into days, you cannot miss sessions. It must be consecutive. Monday to Friday, we do omit Saturday and Sundays by radiotherapy law. However, after that, you start back on Monday again. Now, one thing that's also sort of interesting when it comes to that is we have different phases in the cell cycle. So mitosis is a multifaceted phase, and you have areas where the cells, the DNA is condensed, and then you have areas where the DNA sort of gets they meet and they separate. The thing about it is, according to the phase in the cell cycle that you are in, especially when you're having the DNA meeting together and about to pull apart, you're going to have a lot of information in one area. And when you have a lot of information in one area, what happens is if I cause damage, the DNA on one end is able to depend on the DNA on the other end to build back itself. And what that confers is a sort of radio resistance. So the good thing about breaking up the radiation into days is that when you actually come to the next day, what can happen is the cells or the cancer cells that were in the radio-resistant phase of mitosis may have a chance to get into the radio-sensitive phase of mitosis or radio-sensitive phase for radiation. So that's some of the important points when it comes to that. And then we spoke about oxygen already, but when you actually give time in between the treatments and you eliminate the cells that could be exposed to the oxygen to get the damage from the DNA fixated, what happens is when you get rid of those cells, then you actually reduce the volume of the tumor and you now have more blood flow with hemoglobin and oxygen to oxygenate those cells that wouldn't have been exposed before. So there's some sort of method to the madness in terms of radiation. Now, in terms of radiation versus surgery, this is a common question I get from patients. Why can't you just cut it out? Why? Because sometimes you reach a certain phase. And what happens is if the tumor is more than 4 centimeters, extending to the parametrium, these different high-risk features, even if a surgeon can successfully take it out, you find that most times it is followed by radiation in order to sort of eliminate or sterilize the area. And what they found in this study using this sort of state up to stage 2A patients is that the morbidity of doing an operation for that extensive stage disease is just astronomical, and therefore it's probably best to move on to chemoradiation. Always tell patients that it does not mean that you cannot cure, it just means that the stage is not amenable to surgical intervention. Alrighty, so she was found to have a creatinine clearance of 45 mils per minute. Which chemotherapy drug would you recommend? And this is a trick question. This is also a sort of variable question. But why I'm putting it up is to just give you an idea of what happens in our setting so that we can help in terms of cohesiveness and our referral processes. So is it carboplatin, is it cisplatin, or is it 5-FU? Wow, okay. So a lot of A's coming in for carboplatin, and I will have to agree with you. So in terms of the chemotherapy aspect of things, and you can also look at this table for the radiation aspects and indications, the chemotherapy actually adds a sort of 6% improvement in 5-year survival. However, it is not quite recommended that you use 5-FU by itself, so that's out. So the two competitors here are carboplatin versus cisplatin. Now, carboplatin, most of the studies that were done done with cisplatin, and therefore the option for 5-FU, is 5-FU with cisplatin. Carboplatin, this study actually shows that there's some improvement in the treatment of cervical cancers with carboplatin. However, when do you choose between the two? Now, cisplatin is quite nephrotoxic. So you have to make sure that this patient is able to clear the cisplatin after its administration. And there's sort of a cutoff. So they call it a creatinine clearance of 15 mils per minute. In our setting, we use 70. Why? The access to renal sort of interventions and emergency dialysis is not that forthcoming. So therefore, we sort of keep it a little bit higher. This is coming out of Canada where they're using a cutoff of 50. So therefore, when you count this patient in the vignette, her creatinine clearance is at 45. So therefore, what you can do is use an object or a sort of chemotherapy drug, sorry, called carboplatin, which is not as nephrotoxic and therefore can still derive some sort of improvement in that overall survival benefits. So therefore, if you can't use cisplatin at a certain level for the creatinine clearance, you can always move on to carboplatin. Usually lower than 40, we do not prescribe carboplatin at all. However, you would see that they push the boundaries in international settings where they have access to the nephrology services, and they actually can push it beyond that. So we have a 60-year-old lady who presented post-operation. LND means lymph node dissection. And she has a stage 1B1 carcinoma of the cervix. So she does not have any pyometrial involvement, no positive margins, and her lymph nodes are clear. What would you look for to be absolutely sure that she does not need any further treatment in the form of radiation? Are you going to look at the HP, the performance status, and the grade of the tumor, the size of the tumor, the depth of stromal invasion, or any lymphovascular space invasion? Now, for those who aren't acquainted with medicine, lymphovascular space invasion just speaks to the fact that these cancers, they like to get up and walk. And how do they get up and walk? They go into lanes, roads, and then highways. And those lanes, roads, and highways are through the lymph vessel or the blood vessel. Is it going to be, we're going to look at the grade, the size of the tumor, or the age? You can place your answers. Wow, very good. So we got a lot of these at 78%. So these are the set list criteria. So when I don't do operations, but when a gynecologist or gynecologist does the operation, the first thing we're looking to see if they're positive margins, positive nodes, what's the size of the tumor. However, or if their pyometrium is positive, sorry. However, if that's not the case, you can also start to look at sort of low risk, high risk features. So therefore, they don't have those glaring sort of alarming features, but they do have some features that would make you a bit worried about chances of recurrences, sorry, and that's the lymphovascular space invasion, the tumor size, stromal invasion. Now, what I like to use is something called the GOG score, and this is basically using those factors, but calculating it to try to figure out where the patient lies. And a score of 120 can indicate that this patient may benefit from some form of further therapy post-operation if those risk factors are sort of high in their evaluations. So I have a 24-year-old girl who presented with a stage 3B carcinoma of the cervix on examination, and she has multiple 0.5 centimeter nodes. Now, historically, anything less than 1 centimeter, we sort of watch it. And they are in the para-aortic region, which will sort of confer a stage 3C2 diagnosis if positive. What test would you recommend? Would it be A, a PET CT, B, an MRI of the abdomen, or C, a biopsy of the para-aortic node? You can place your answers. So most persons said PET CT, and that is absolutely correct. Well, not most persons, actually, there's some persons saying MRI. But the PET CT is probably best because it gives an idea of functionality. So in this instance, we're able to identify extensive nodal disease. In some instances, you're able to identify metastases, and in some instances, you're able to identify another primary cancer. In our setting as radiation oncologists, we can actually fuse the PET CT or superimpose it on the planning scan. And then this area in red, I'm now telling the machine that this encompasses the cancer and the therapist must treat this entire area. So the PET CT, in fact, helps us with our planning. Now, she was also found to have unilateral severe hydronephrosis. The next step would be, is it to do chemoradiotherapy? induction chemotherapy or percutaneous nephrostomy tube? Yes. Now, this is a picture or a video of what it looks like when we spoke about the new type of treatment where we're able to superimpose the CT scan from the planning and the CT scan from the day of treatment. And this is what we call a cone beam CT. And the importance of this is that we're able to see that we are targeting the tumor every day, which is what happened for that patient. Alrighty, what is the dose of radiotherapy required to eradicate this patient's cervical cancer? Now, initially, and I said this profoundly, that the dose that I was talking about earlier, that 45 gray and 25 fractions, was an initial. What happens when we actually trying to cure the cancer? Is it 45 gray, 85 to 90 gray, or is it just 20 gray? And for those of you who said B, you're absolutely correct. It is 85 to 90 gray. Now, 45 gray is what we give to the entire sort of cervical area in addition to the lymph node areas. However, to eradicate cervical cancer, we take the dose a little higher. So that's why we have phase 1 and a phase 2. By the end of the phases, you should have reached to this sort of dose. However, the best way to do it is with brachytherapy. Now, the brachytherapy, brachy means close to. So when you do the brachytherapy and you put these metal objects inside the patient, what happens is the radiation no longer becomes long rays, it becomes short rays. As a result of that, it doesn't affect the neighboring organs, including the blood and the rectum as much, and therefore you're able to fully get the heat or the eradication of the cancer. Some patients are not amenable to this type of procedure, so therefore we'll have to give further radiation from the outside, putting the patient at risk for more bladder and rectal toxicities. The radiation that we give in terms of brachytherapy comes in two forms, slow form and fast forms. Unfortunately, we only have access to the slow form, which can take a matter of days of immobilization, so the patient is unable to move while the treatment is happening. However, the fast form is within a matter of minutes, and that is coming soon to Jamaica by the end of this year. In addition to that, things have gotten fancier where they're able to use CT scans to identify the residual cancer after the 45 gray phase and even target it even better. Of course, as well, the slow form or the low dose form that we have in Jamaica, we as the physicians, we actually place the radiation inside. So there's some sort of exposure to the actual physician that will be eliminated as well with the fast high dose form. In addition to that, we have to be cognizant that in our setting, we see quite advanced disease. The ideal patient should have disease limited to the cervix by the time the brachytherapy comes around. However, if that doesn't happen, we have this new technology internationally called interstitial needle. So what happens is, even though I put the radiation inside the cervix, you can put needles in the areas of tumor that extend beyond the cervix to treat it to completion. So you are about to commence radiotherapy and the linac goes down. I think we're all familiar with that. And you are worried about disease progression. What is the best option? Is it radical hysterectomy, induction chemotherapy, or adjuvant chemotherapy once radiation has finished? And I think everyone listened to Dr. Barnes because induction chemotherapy is now becoming popular. Now, this is a trial called the Outback trial, which talks to the answer C option, which is adjuvant chemotherapy. And that, in fact, showed no glaring benefit in terms of giving chemotherapy once the radiation has finished. A radical hysterectomy is not going to be possible. As I said, it has to be quite confined. After a certain stage, the surgeon will become quite apprehensive. So therefore, induction chemotherapy is now something that came out of the UK. And this clinical trial, what they did is they gave 6 weeks of carboplatin and paclitaxel before radiation. And they actually found an overall survival benefit, meaning that this thing actually in advanced cancers was able to improve the chances of cure. And it proves beneficial in our setting because we are in fact now able to give some sort of temporizing measure whilst awaiting radiation. These are just the benefits in terms of overall survival and disease-free survival. So the only concerns with this new procedure is that the studies were done in the international settings where they had access to machines. So therefore, after getting the induction chemotherapy, there was a 7-day break and they started with the radiation. If we have significant machine downtimes in our settings, that may be a challenge. And in addition to that, we see patients for chemotherapy with the radiation. So therefore, we were a bit worried about the sort of low blood counts during the treatment. Maybe an issue, not so much. And in addition to that, in the study that they did, most patients were stage 2. We see a lot of stage 3s. However, we would be able to use this opportunity to see if it is effective in those patients for more low to middle income countries to generate data. Now we are going to just summarize how does radiotherapy work. It causes DNA damage using the rays that we spoke about that come from this machine. In addition to that, chemoradiotherapy is the treatment of choice. You have one phase where you go to about 45, it could be up to about 50 gray, but at the end of the day, with brachytherapy, you'd want to get to as high as 85 to 90. In addition to that, where are we in Jamaica? We have access to PET CTs, Linac-based treatments with the cone beam CTs for us to see what we're doing daily, and high dose rate of fast brachytherapy is coming soon. And in addition to that, this induction chemotherapy, where you're given the chemotherapy for 6 weeks prior to treatment, is new and should be implemented in our setting because of its benefits in terms of a temporizing measure. Back to the question and answers. In which year did KPH open its doors? And those who said A, you're perfectly correct, 1776, the same year that America gained independence. We started KPH. 1892 was the Victoria Jubilee Hospital, and 1953 was the University Hospital of the West Indies. I'd like to thank the Jamaica Cancer Society, the St. Joseph's Hospital National Cancer Treatment Center, the Kingston Public Hospital, the Radiation Oncology Center Jamaica, and the Prime Medical Center, some of the places that I frequent, for assisting me and for giving me the opportunity to present. And if any questions further, I'll be happy to answer. Thank you very much.
Thank you again, Dr. Pemberton. No disappointment there. Very interesting presentation. I think we all would agree. And very comprehensive presentation. I think most of us at different levels and of provision of care would be able to fully appreciate what was presented. Sorry for that interruption. So our next presenter would be that of Dr. Pernell Bell, who is a clinical psychologist representing on the psychological impact of a cancer diagnosis. Dr. Bell is a licensed clinical psychologist and human resource consultant with combined experience 25 years. Motivational speaker, author, columnist, received extensive academic training in Jamaica and the United States of America. She has a PhD in psychology, a master's degree in human resource management, a postgraduate certificate in clinical psychology from Walden University. She is currently a professor at the Yorkville University and City University in Canada, where she lectures in ethics and legal issues, human development and diversity and culture. She has made significant contributions to the field of psychology and is a pioneer in the field in Western and Northeastern Jamaica. So Dr. Bell, the psychology impact of cancer diagnosis.
Thank you so much, Dr. Daly, and thank the Cancer Society for inviting me. And I'm very, very honored to speak on this topic that I think is so neglected, looking at the mental health impact on our cancer patients. I want to begin by talking about a client, I will name Jeffrey for confidential or purposes. And he actually was a patient of mine who related his experience having been told about his cancer diagnosis. And Jeffrey said when he heard that he was diagnosed with a very rare cancer, that he felt as if he was hit with a ton of bricks. He said, I heard the doctor, but I went off into a dissociative state. It felt like I was in a dream and would wake up happy and at peace because this was not for real. He said, I zoned out and did not hear what the doctor was saying other than the word cancer. I saw myself outside of my body dead. So just hearing the doctor say the word cancer, that big C, can have a profound effect or impact on a person who has just been diagnosed with cancer. So a diagnosis of cancer begins a long journey, as we all know, of an impact of physical and, by extension, affecting the mental wellness or mental health. The journey of caring for that physical health could actually take a toll on the mental health. When we look at the enormous costs caring for self, this can also have that tremendous impact on the patient's mental well-being. Their physical, physiological, and financial health can change tremendously. So really, I'm very glad that this aspect has been of psychological health and wellness and the impact that it has on persons diagnosed with cancer have been included in this discussion, because doctors should be cognizant of the fact that being given a diagnosis such as a cancer could have a psychological impact, mental impact on the cancer diagnosis. It can trigger, for example, all those psychological impact that we're going to discuss as we go along. Actually, in my research, studies emanating out of the US have shown that cancer care doctors misinterpret patients' distress or psychological disorder as much as 35% of the time, because invariably maybe their focus is on the medical aspect of the diagnosis. This means that once a diagnosis of cancer is given, that doctor should really include referring the client for some kind of psychiatric or psychological intervention because of the overall impact that it will have. Invariably, there may be a stigma associated with mental health, and so many of the clients may resist. But again, doctors should really tell the patients about their diagnosis and should include that option of seeking psychological, psychiatric intervention because of that journey that could result in a psychiatric as well as a psychological diagnosis. As I mentioned, Jeffrey, on the onset, I will just give a quick overview of the journey with cancer. 30-year-old Jeffrey, at the onset of my discussion, was diagnosed with a rare cancer, and he worked as an accountant and began treatment for cancer. He ran into financial difficulties. He could not afford after a while to keep up with the cost of treatment. His mother lived abroad and was not as supportive as he would have liked. So he took to social media for help and created a GoFundMe account and was able to garner US $10,000 from the venture. And he asked his mom to collect the funds because, as we know, the funds are not directly sent to Jamaica, but a US account has to be used. So what transpired is that the mom actually took some of the money of the funds, and that added to Jeffrey's distress. And this is how he came in contact with me, because he was referred for psychotherapy. He reported that too, he didn't feel like he had the support of doctors who he believed was not providing him with up-to-date information on his progress. He eventually lost his job and faced severe financial issues. And in many cases, this may be a case, not the typical case, but a case that I actually had to deal with. So Jeffrey's recurring concerns was anxiety, and anxiety surrounding his own well-being, his ability to care for himself, and also the pervasive sadness that he was experiencing because of all that was happening to him. He also feared, because at one point he was said to be cancer-free, and then the cancer came back. So, but he anticipated or had some fear around the cancer recurrence. There was distress too in terms of the overall adjustment to his whole lifestyle because of the fact that he was diagnosed with cancer. Certain other healthcare and societal related resources that he didn't come with a cost and that he didn't felt he had access to. So many persons who are diagnosed with cancer face multiple psychological issues that should never be overlooked. Sometimes there's a lack of support, as we mentioned in Jeffrey's case. Sometimes there's a breakdown in relationships, fractured relationship due to the illness that the individual maybe is going through. Sometimes it affects their lack of intimacy due to changes in the relationship. And then body image issues resulting in self-esteem issues could arise. Uncertainty of existence and fear of dying, and certain negativity that is associated largely with the fact that the person is anticipating dying. Anger and fear too may be a part of the whole psychological process here. And anger with God, anger with other persons, anger with self, and the fear again of dying and not able to care for self. As a result of that too, most times the psychological impact results in anxiety and depression for the individual. And that lack of social support could create that increased stress for the cancer diagnosed person. Family members, and we are again appealing to doctors that if it is at all possible, doctors should actually include in the discussion family members, spouses, children, and friends, and let them see how they too can help with giving support to the patient. So that social networks should be encouraged to listen to those unique needs and concerns of the patient. A support network that greatly help will reduce the stress dealing with the cancer. And lack of social support actually results in higher anxiety levels and lower quality of life and higher incidence. That's what the studies are showing. Higher incidence of depression and higher levels of anxiety. Lacking that social support, the propensity of dying earlier, or it doesn't like extend the person's life. What happens in this case is the likelihood of the person wanting to die. So suicidal ideations sometimes become very evident. So that a good social support network has been linked with an increased quality of life for cancer patients undergoing treatment. And nearly all studies have shown that the psychological benefit of cancer patients who attend support groups. So that's like so very important when it comes to social support. Most patients attending support groups actually feel more emotionally fulfilled. And that is because human beings are gregarious beings, and they still, in the time of a crisis or distress, they want to know that they are supported. And groups help to manage the depression and the anxiety or avert them in instances. So having a support group is vital in this stage. So anxiety and what doctors should be looking for in helping the client move forward is that they become worried over their diagnosis, and this worry may actually raise anxiety levels. And the raising of the anxiety levels could result not just in anxiety, but result in an anxiety disorder, which would then become a psychiatric issue. So what would doctors be looking for? Patients become more restless. They have difficulty concentrating and feeling wound up on edge, having irritability, the inability to relax, and difficulty controlling their worry. Other symptoms may include literal shaking, signs of nervousness, irregular heartbeat, and extreme levels of worry. And these anxiety may occur at the beginning and during the cancer screening, diagnosis, and treatment. It is said that in the US, I couldn't find certain statistics here in Jamaica, but 48% of cancer patients report high levels of anxiety, and actually 18% of those were also diagnosed with an anxiety disorder. It is said too that we should look out for patients who are unmarried and undergoing treatment. They are at higher risk for anxiety. Women too are at higher risk than even men in showing this level of anxiety. The level of anxiety may cause so much distress for this patient that it interferes much with their ability to carry out the treatment and go through the treatment in a way that would be beneficial for them, which would be aiding in their recovery. Depression too is another psychological mental health issue that may arise. And it is said that between 16 to 25% of cancer patients may develop depression. And again, doctors tend to not recognize, the primary care physician not recognize 35% of the cases are not usually recognized and go untreated during their cancer treatment. So what we're actually saying is that depression and anxiety is more common in cancer patients than actually in the general population. More so, the need for doctors to be aware of the mental health issues and treat alongside the treatment related to the cancer. And as we know, we're looking out for the signs of depression. There could be depressed mood lasting for more than nearly every day, noticeable loss of pleasure or interest in normal activities for most of the day, nearly every day. And then there could be significant loss in weight and appetite, sleeping more than usual, fatigue, feelings of worthlessness, and inappropriate guilt, and decreased ability to think or concentrate, and interestingly, frequent thoughts of death or suicide. So we want to be cognizant of those issues. We also must recognize too that cancer patients may go through grief. So it's kind of an anticipating of dying. So it's a grief process that starts. That could begin with the client denying, having some anger around that issue, then bargaining. If I could live my life over, I would do this, that, and the other. And then there is depression until the client may come and accept. So we also have to make a distinction or a contrast between that kind of anticipation of dying to depression. And some of the notable contrasts would be the patient experience in grief. The patient will experience some somatic distress, loss of usual patterns of behavior, agitation, sleep issues, appetite disturbances, decreased concentration, and social withdrawal. In depression, the patient experiences similar symptoms, plus hopelessness, helplessness, worthlessness, guilt, and suicidal thoughts. So we also want to make note of those impacts. Grief is also associated with the disease progression, and depression has an increased prevalence of up to 77% in patients with advanced disease, pain, or major risk factors. The patient may also, in the grief, retain the capacity for pleasure. In depression, the patient may enjoy nothing at all and have a feeling of being sad most all the time. Grief tends to come in waves, but depression tends to be constant, and the patient may wish to die, but in depression, sometimes there is a persistence in suicidal thoughts and wanting to die. So depression is really continue to include or come about because the person may be experiencing some psychological distress, biological problems. It may be the side effects of medication too that could bring on the onset of a depressed feeling. Chemotherapy is also part of that too. And they may have some thyroid issue that needs to be treated. That is also bringing on the depression, and inadequate diet. Depression that goes untreated will increase the risk of the cancer patient going into a state that would affect how they're going to make decisions, how they're going to make decisions in terms of their treatment, and their recovery. So again, that has to be taken into consideration. It is then important that doctors become aware that there is a psychological component to that diagnosis. And so it is imperative that they give the patient the option for seeking psychiatric as well as psychological intervention, because this should be a natural part of the cancer care that is there. Due to the implication of the psychological impact of the disease on the individuals, then it makes this so necessary that this become part of the overall treatment of the patient. Doctors should have screening tools for anxiety and for depression from the onset, during the treatment process. It is important that that kind of diagnosis be made. And again, we are emphasizing the need to incorporate that psychological piece into the treatment modality of persons diagnosed with cancer, because it can go a long way in actually helping the patient to recover faster, because they are not dealing with those the mind issues, but focusing on, in a healthy way, on treatment that they are now getting. Thank you very much. I think this is an overall view of understanding some of that psychological as well as mental health impact on a client who has been given a diagnosis of cancer.
Again, thank you very much. And thank you for listeners and participants. It's been a very fulfilling program. And we're here at the final visitation, actually, from Mrs. Bethune Webb-Polk, who would be giving us an inside view in terms of an ovarian cancer survival. So she will wrap up with her testimony.
Good afternoon.
Afternoon, welcome.
Hi, thanks for having me. Firstly, I'd like to say thanks to the JCS and all the organizers for inviting me on this forum. My name is Bethune Webb-Polk, and I am a classic case of misdiagnosed. My health history started, and I will just go through some of it and the abnormalities that I had. I checked the key point indicators, I checked many of those boxes. At age 17, I had my first period. And of course, my sisters who were younger than I, they were at 9 and 12 respectively. At age 20, I had irregular periods. Throughout my 30s, I was diagnosed with polycystic ovarian syndrome. And at that time I got married, was trying for a family. That did not come to fruition because I struggled with infertility issues. At age 40, though my period was irregular, I had the last 4 days. And as such, I noted that they had reduced to 2 days. So I went to my doctor, and my doctor said to me, well, you know, you're in your 40s, you're getting there to the menopausal stage, so don't worry too much about it. And of course, I believe I can speak on behalf of all females on this forum that I was elated because nobody likes period. So I left the office and I was in total glee. I'm only down to 2 days. Apparently, those 2 days turned out to be a nightmare because I dubbed it tumultuous. My period was just tumultuous for those 2 days. I'm passing these huge clots, I call them body parts. And the pain was a 10 plus. I went back to the doctor, dreading another period. And I explained what was happening. He did a pelvic examination, and he reassured me that I'm well, there's nothing to worry about. My instinct kicked in, and I would not leave without a requisition to do an ultrasound. I told him I wanted to look at the girls upstairs, and I make reference to my ovaries and my reproductive organs there. So he gave it to me reluctantly, and I went and got the ultrasound done the same day. In doing that, the radiographer said to me, Bethune, I am unable to see some things, and I'd like to do a transvaginal ultrasound. I agreed, and he proceeded. That's when he said to me, I am not able to see your reproductive organs. And with that said, I am going to ask that you go directly to your gynecologist. I left in much hurry, and I went to see my gynecologist a couple of days later. I'm never normally one who is quite compliant from time to time. And as such, I stayed a couple of days later, I went to see the doctor. Now, I dubbed him the investigator, motivator, drill sergeant. That's who he is in my book. And of course, Doc, if you're on this platform, I am saying thank you again for putting up with me and my rhetorics and just pushing me all the way, because you really saved my life. He did thorough investigations, thorough and costly investigations. But I did them, and I remembered I would complain, and he would say, we need to find the answer. Eventually, on the last quest of those investigations, I did the longest MRI I can recall in my life then. And after that study was done, I was told I need to do a chest x-ray. So I was asked to sit in a room at the facility. Whilst I'm there, I saw this huge screen, and I'm looking at an image. I was waiting for a while. So I was there, and I spoke out aloud, because this is just who I am. And I said, how uncouth they are to leave someone's anatomy on the screen like this for others to see. I trust they won't do that to me. So whilst I'm there, the Jamaican got it to me, and I had got nothing to do. So I'm just sitting there, and I'm looking at it, and I said, let me figure out where on this person this is and what it is. So I moved closer to the screen, and I began to snoop around looking at the image. Whilst I was there snooping, I recognized the date of birth that it matched mine. So I said, oh, coincidence, the person has my date of birth. In the right-hand corner of the screen, written very small, my name, Bethune Webco. I became overwhelmed. Stoicism set in. I didn't know how to move forward. So I proceeded to do the chest x-ray in silence, sheer silence. I later met up with my gynecologist, and my CA-125 came back, and my tumor marker, ladies and gentlemen, it was 3020. From there on, my world went into what we dub a rabbit hole spin. And everything just kept on coming at me like a freight train. He, as I said before, him being the drill sergeant that he is, kept on pushing me to do other stuff. And so by the time you turn around, I'm in the hospital doing a biopsy. The biopsy came back, and I was staged. I was diagnosed with ovarian cancer. And ovarian, not just ovarian, but stage 3B, low-grade serous carcinoma. From there, it was surgery. I had no time to breathe because everything was just going so quickly. And then I started chemotherapy as soon as I think I could scab over. That's how I look at it, yes? But this afternoon, I'm able to smile. I listened. I've been in from morning listening to all the presenters. And I am able to say thanks to God, that today it's 6 years, 8 months, and 2 weeks since I am cancer-free from this egregious disease. I want to thank God. I want to thank the doctors for being knowledgeable, astute, patient, caring, thorough, and very honest with me. And also my husband, who was my caregiver and still trying to be, and also my biggest support. As Dr. Bell alluded, depression. I did not fall into depression because of what my personality is, but at some time when I'm sitting alone, I become reflective to the point where I become reclusive. Yes, I reckon Dr. Christmas had spoken earlier about the financial strains. And it doesn't matter how much insurance you have, it's never enough when it comes on to cancer. So it was really challenging financially. It takes a toll on your body, it takes a toll on your pockets, your family dynamics, you know, because you're wondering also if you will make it across the threshold. During the time when I was ill, I opted to seek information. Sadly, I could not find nothing that speaks to ovarian cancer in this country. And please note on the screen, this is what I saw at the MRI place, the image on the screen that speaks to the cancer. I'd even started to calcificate in some areas. So that's me, my anatomy that I was looking at. I began to go about and in search of information, there was none. I sat with my doctors and all three of them gave me verbiage to put together a pamphlet. And I did a flyer, and that flyer I started to disseminate across the length and breadth of this island. My surgeon noted my efforts and he said to me, you know, there's a group in the UK called Overcome. Perhaps you can speak with them because he knows I have strong affiliations with the UK. So yes, I joined the group Overcome in 2019. And they sent 2 trustees to Jamaica to support me. And of course, along with my oncologist, we all went into corporate offices and we spoke about this silent killer. A lot of people didn't even know that their ovaries could be impacted. I have been doing it. I have not stopped since my diagnosis to now. I would like, if I may, use this medium to implore the doctors on this platform to help us who are diagnosed with ovarian cancer. Give us more information out there. Have flyers so that persons can be cognizant of some of the symptoms. For example, the UK have this flyer I have on the screen that speaks to the BEAT acronym. And that's important for women to note. Though it correlates to the irregular menses, yes, at the end of the day, I think knowledge is power. And so more needs to be done to sensitize females about this. Also, I'd like to touch on the psychosocial support that I don't think is at the forefront here in Jamaica. The psychosocial support for patients and also oncology patients and also their families. In the UK and perhaps in the Americas, they have care managers. Now, here in Jamaica, the new thing is to give us a flyer in lieu that we go home and read or send us to a website in hope that we will go there. Please be mindful that not many Jamaicans are that learned. Medical jargons are hard to understand, let alone to comprehend, to flesh out, to move forward. I'd also like to speak to the fact that, let me give an analogy. So you offered chemotherapy administration, and I go home, and that Kytril causes constipation so badly. And then I eat something, and then I develop mouth ulcers. Within that 3-week time span, I'm struggling. I'm not that solvent. So my chemotherapy rate would be $60,000 per administration, for argument's sake. So I've already saved that 600,000. I'm sitting on it like a duck. But then I don't want to touch it, but I'm reeling from something. And so by the time my 3 weeks come around, I'm so sick. Yes, I have no one to call, because if I come to you, perhaps I'm going to have to pay again and delve into that funds that I don't have the support mechanism to back me up. So many patients that I've dealt with out there, and it has never happened to me, thank God, but many patients out there, they're not able to do that. They're not able to come back to you for a paid visit to say, this is my plight. Therefore, I'm imploring you all to consider, there are literatures, there are materials there to train your office administrators, your nurses, to become care managers, to lend support to oncology patients, so that they can call and say, I can't go to the bathroom, for example. I can't eat a meal because my mouth is full of ulcers. And so you can stem that, because once it's escalated to you, you then write a script, yes? Or you call it in, and that will fix the issue, rather than that patient is asked to suffer in sheer silence. Also, whilst I'm on the psychosocial support, I'd also like to speak to the fact that if your belly has cancer, it's inevitable sometimes the risk is higher for the breasts, and vice versa. The same drugs that are used for breast cancer to treat breast cancer patients are the same ones that are used. I listened keenly today to some of the names, the carboplatin, the paclitaxel, and so forth, that are used for gynecological cancers. I'm imploring you all to speak with the powers that be at the NHF to give us a reprieve on even the pre-meds out there. Because when I speak to patients who are reeling from this disease, affordability is not one that is easily attained and can be maintained. And so we're not many. In terms of the numbers here, are not as large as the breast cancer numbers and the other cancers that are ahead of us. But at the end of the day, we too are in the back end crying out, help us, help us. Yes. I want to say thanks to the doctors who continue to delve deeply and more deeper into trying to find a solution. And even Dr. Danbury spoke earlier about there is not one thing that can concretize a fulsome diagnosis. Yes, you go to check your breasts and you can have a scan done, the transvaginal ultrasound, CA1, but there's not much that can be done. And because everything is so vague, it's so difficult. But my journey continues. And though I'm cancer-free and grateful, I still reel from the ills of the chemotherapy. I have neuropathy. I have calcium and bone issues going on, but I keep going. And I'm most grateful that at least one of us are alive to say thank you all, to all of you in back end working assiduously, saving our lives every day. Thank you for listening, and thank you for allowing me to share my story.
Thank you too for sharing such a heartfelt rendition of your experience. We have come to the end of our program. Thank you to our listeners who have been there until the end, and especially those who have seen us from the beginning. I'd like to thank the Jamaica Cancer Society, Dr. Banbury, the sponsors, presenters, all of our attendees, and of course the team, yourself, Diane Thomas from the Office of the Jamaica Cancer Society, our technical support, David, Miguel, and Richard. Once again, thanks for coming out. CNEs will be available. You can reach out to the Jamaica Cancer Society and have a good day. Thank you.
And thank you to Dr. Daly for coming out and being our moderator today. We appreciate it. Thank you so much.
You're welcome.